Hello, good afternoon. So it's time to start. So my first order of business to apologize on behalf of Professor Aiken, who is running a little late. So I'll do the welcome on his behalf. I'm Dr. Deanne Soares, for all of you who do not know me. I am the chair for the afternoon. So I would like to welcome you all. And we do have an online audience, I'm happy to report. So there are people in the theater and out of the theater and possibly overseas. So for those of you who haven't registered, if you need your CMEs, you can register. The QR codes are on both of the back windows at the exits. And there's also a QR code there to access the program. Are you all still hearing me? Okay, right. So welcome to our annual departmental clinical research meeting. And I would like to, we don't have a lot of time to spare. So I'd like to give a special welcome to our judges, Professor Marvin Reed, Professor Maxine Gossel-Williams, and to Miss Shelley McFarlane. Where's Shelley? Okay, and I think all my presenters are here, and my timekeepers are here. Thank you. And our administrative authority, Miss Bennett, is here. She has been hard at work. All the programs and everything have been sorted, and we have QR code and fancy technology thanks to her efforts. And so, and Sister Booth is here. She's been a stalwart over the years. I recognize some of my consultants from A&E, from anesthetics, from GU, and I think we'll just get started. So our first presentation is from Dr. Bradshaw. We're going in alphabetical order. So nobody please feel upset that you were last. We are not responsible for your name. I know that pain. My name begins with S. So I used to be one of the last ones for exam. Had all day to get nervous. All right, so here comes Dr. Bradshaw, and he's gonna be talking to us about TURP, and he's from the division of urology in the surgery section. Dr. Bradshaw?
All right, thank you very much. Good afternoon. My name is Levi Bradshaw. I will be presenting the first case on behalf of the urology team here at University Hospital of West Indies. So this study is entitled Factors Associated with Prolonged Length of Stay, Post-Transurethral Resection of the Prostate at the University Hospital of the West Indies. So benign prostatic hyperplasia is a prevalent condition among men, aging men, characterized by the progressive bladder outflow obstruction that significantly impacts their quality of life. By the age of 50, approximately 50% of men exhibit some evidence of benign prostatic hyperplasia, with the prevalence increasing significantly with age. Transurethral resection of the prostate remains a cornerstone surgical intervention in urology for managing patients with BPH, particularly in men with refractory medical therapy or in emergency cases such as patients that have complications such as hemorrhage. Post-operative length of stay following TURP is a critical metric directly influencing patients' outcome and also healthcare resource utilization. Identifying predictors of prolonged length of stay is critical for optimizing clinical pathways, reducing costs, and improving patient outcomes. So the aim of the study was to determine the predictive factors associated with prolonged length of stay for patients who underwent TURP between the years 2015 and 2024 at the University Hospital of the West Indies. Our methods, so this was a single center retrospective cohort study, including all patients that had underwent TURP during the study period, where it excluded patients that had incomplete medical records and also patients who had severe comorbidities, which may have independently affected the patient's length of stay post-operatively. The variables included dependent variables, the length of stay, which we dichotomized into standard length of stay, which accounted for 1 to 2 days post-operatively, versus prolonged length of stay, which was more than 2 days post-operatively. Independent variables included demographic data, such as the age, the comorbidities of the patient. It also included the type of admission, whether elective versus emergency admissions. Preoperative factors, such as the patient's PSA at the time of surgery, their prostate volume, catheter dependency. Intraoperative factors included the operative duration, also included the type of anesthesia that was administered, whether general versus spinal anesthesia. Post-operative factors such as complications, blood transfusion requirements, and whether or not they had a trial of catheter and the outcomes of same. So the data was extracted using a standard data collection sheet. We had first gone through the respective surgical logbooks, and then subsequent to that, we examined the electronic medical records carefully. The data was then secured on encrypted password protected devices, and access was only limited to the research team. To protect patient confidentiality, all personal identifiers were removed and patients replaced with a unique study ID. We had utilized convenience sampling for the procedure. The sample size was calculated to be around 250 patients. Limitations included selection bias, as in keeping with our convenience sampling design and also retrospective design of the study. Data analysis, so the descriptive statistics that we use included mean, median, proportions, standard deviations, and interquartile range. We use comparative analysis, including student t-tests as well as Pearson chi-square tests for evaluating continuous versus categorical variables, respectively. Binary logistic regression was also used to calculate unadjusted and adjusted odds ratios to identify predictors of prolonged length of stay. SPSS latest version was also used for our analysis. So we now move into the results of the study. So this first figure illustrates a line graph that essentially shows the average length of stay per year from 2015 to 2019. Going for the first 5 years, 2015 to 19, we noted that there was an average length of stay of 2 to 3 days post-operatively. As we approached the 2020 year, we noted that there was a sharp rise in the length of stay post-operatively in keeping with the COVID-19 pandemic. And as we know, most of these cases were emergency cases, and emergency cases tend to be more complicated, and therefore these patients would typically require a longer length of stay to monitor them for their recovery. As we went post-pandemic, between the years 2021 and 2023, we noticed that the length of stay average came down back to the normal 2 to 3 days post-operatively. However, in 2024, we noted that there was a rise of length of stay going all the way towards 4 days. And that makes us wonder whether or not there's some change in our surgical strategy, if there's some change in the type of anesthesia that we administer, or if we are just encountering more complex cases. But it'll be interesting to follow this trend going forward. Table 1 illustrates descriptive analysis of demographic and clinical characteristics in TURP patients. Based on this table, the average length of stay for patients in this cohort was 2.9 days. The average age of patients was 69 years of age. The average operating time was 1.5 hours, with the highest operating time being 4.8 hours. The average prostate volume that we operated on was 86.2, with the largest prostate being 400 grams. The average PSA of the patients in this cohort was 34.8, with the highest PSA value being 2,646. This next table illustrates the type of surgeries that were done. Transurethral resection TURPs only had accounted for 124 cases, whereas patients that had TURPs in addition to other procedures had accounted for 121 cases. Additional procedures such as cystolytic epoxy, endoscopic fragmentation of stones had accounted for most of the cases that were associated with TURP. This next table outlines some of the associations such as the demographic, surgical, preoperative, postoperative factors, and the associations with the patient's length of stay postoperatively. Right away, we see that age had no significant association with the length of stay of these patients. However, if we move down the table, we notice that as operative time had increased, there was a statistical significant relationship with same. The prostate volume also had an increase in length of stay in majority of the patients, and this was a statistically significant relationship. Additionally, the type of admission also played a role in the length of stay of these patients, where we found that patients that were admitted under emergency settings had a prolonged length of stay in comparison to patients admitted under elective settings with a statistical significance of p-value of 0.001. Additionally, the type of anesthesia also had a significant correlation, where we noted that patients that underwent general anesthesia for their surgeries had a significantly longer or prolonged length of stay compared to those that had undergone spinal anesthesia, who had a standard length of stay of 1 to 2 days. Complications were also significantly correlated with the length of stay. Patients that developed complications had associated prolonged length of stay, and this was not surprising, as clearly patients that develop complications will require some additional post-operative monitoring. There was also a significant relationship noted with patients that had trial without a catheter. This bar graph illustrates the relationship between the mean operative time and the length of stay, where patients that have who were noted to have a longer operating time had a statistically significant relationship on t-tests with a prolonged length of stay. Similarly, in this bar graph, patients that had a long or higher prostate volume were noted to also have a prolonged length of stay, and this was found to be statistically significant on student t-test. So we went on to the further analysis, and this table has illustrated the independent and adjusted predictors of prolonged length of stay in patients undergoing TURP using binary logistic regression analysis. And what we noticed is that patients that had prolonged operating time had maintained their statistical significance in both univariate and multivariate analysis. Additionally, patients that had emergency cases had a very high odds ratio when compared on both univariate and multivariate analysis. Additionally, complications had maintained their statistical significance on multivariate analysis. The factors that lost significance on multivariate analysis included prostate volume, the type of anesthesia, as well as the trial without catheter. And this was possibly because the effects have been affected by other variables. This final table illustrates post-operative complications of patients that underwent TURP and the associated mean length of stay of each of these patients. The most common complications noted to be hematuria, with an average mean length of stay of 3.6 days. Additionally, the patients with the longest length of stay was noted to be patients that had urinary tract infection, patients that had chest infections, and also deep vein thrombosis or pulmonary embolism post-operatively. So in summary, operative time, emergency admission, and complications were significantly associated with prolonged length of stay post-TURP surgery. Operating time, we showed that each additional hour increases the odds of prolonged length of stay by 2 times. Emergency admissions was the strongest predictor of lengthy post-operative stay, highlighting the need for proactive management. Complications had doubled the odds of prolonged length of stay, underscoring the value of preventive strategies. Making adjustment to these factors may improve patient outcomes and reduce health costs utilization. Thank you for listening.
Thank you very much, Dr. Bradshaw. Are there any questions? Sure.
I opted to use mean length of stay versus year. I think it was easier for the analysis to be done that way, meaning that we could compare a continuous variable versus a categorical variable. Person's chi-square would have helped us in that analysis. It might vary to some extent, and that depends on multiple factors. So in this study, on the multivariate analysis, we noted that patients that had complications influenced their length of stay, patients that had emergency admissions, for example. I would expect a somewhat wide distribution.
For your multivariable model, how did you enter the factors in that model?
Well, that was actually done by a statistician, so I wasn't quite involved in inputting the data for that specific test.
Okay, all right.
Thank you for your presentation. Just one question. Were there any results that you didn't expect?
Results that I did not expect. Not really. I think it was more in keeping what we did expect, complications, emergency cases. Yeah, that was pretty much in keeping what we expected from the study. Definitely.
All right, one last question. In your final model, or when your table, the column that had your so-called multivariable variables, you had valid cases of 138, yet your sample was supposed to have been 250. How do you expect those missing variables may impact the results you received?
So I should have pointed out that the major limitation of the study was missing data. And so we couldn't account for all the factors or variables that we needed. But if we did have all those factors and variables available, I suspect that many of the relationships would have turned out to be significant. So for example, operative time would have maintained its significance and so forth on multivariate analysis, possibly.
Is there anything that you could have done to help us appreciate or come to the same conclusion that you're coming to?
Yeah, I suspect if we included a flowchart to allow the audience to identify the missing data, like what we started with in terms of our sample size and what accounted for our limited sample size at the end, that could have definitely helped you to understand why we got the results that we got.
Okay, thank you, Dr. Bradshaw. Thanks, Prof. Reed. Thanks, Ms. McFarlane. Next up, we have Dr. Christian from the Division of Pediatric Surgery, who is going to tell us something interesting about Hirschsprung's disease.
Good afternoon. I am Dr. Sasha Christian, and I will be presenting an ongoing research project that's taking place in our Department of Pediatric Surgery entitled An Evaluation of the Risk Factors Associated with Poor Post-Operative Outcomes in Children Treated for Hirschsprung Disease in Jamaica. And this is a 10-year review. My supervisor is Dr. Simone Dundas-Spells. So let's start off. What is Hirschsprung disease? This is a congenital condition that is characterized by the absence of ganglion cells within the rectum that often extends proximally to the colon. If we can look at this pointer here, you're not seeing. Okay, but we can look at this picture here and we see a narrowed rectum at the lower portion of the image. That area is absent for ganglion cells. And just proximal to that, there is dilatation of the bowel. And so stool cannot pass freely throughout the entire colon and rectum. How do we fix this condition? It's purely surgical through a pull-through procedure. If you can look at the diagram, that green area in the first picture will represent the portion of bowel that is normal, that has ganglion cells. The red portion does not, and stool cannot freely flow through that area. What we will do is resect that red portion, and as you can see in the last image, bring down that well-ganglionated bowel towards the colon and the anus, and perform a primary anastomosis. So of course, post-operatively, everybody wants good outcomes, the patient, the surgeon, as well as the parent. However, internationally, it has been said that up to 40% of patients experience constipation still at the end of the procedure. Up to 37% of them have Hirschsprung's associated enterocolitis, which is essentially inflammation of the bowel. And up to 74% of them experience fecal incontinence. So what do we know about our Caribbean population? Unfortunately, the data is quite limited. Vincent et al. In 2009 in Barbados conducted a study looking at 27 patients who had undergone pull-through procedures, and they said that 69% of their patients did quite well, having good bowel function. Our very own Professor Duncan et al. In 2011, right here in Jamaica, looked at adult Hirschsprungs, which is essentially Hirschsprung's diagnosing patients after 10 years of age. And he looked at 11 patients and the outcomes were good. However, one patient had significant obstruction requiring a second procedure, and 2 patients had life-threatening anastomotic leaks. And because of that, it was suggested that patients who have adult onset Hirschsprung's disease and undergo a certain type of procedure called a Swenson's pull-through really should have a protective colostomy. What else is known about risk factors that may potentiate poor outcomes? Well, the literature says if the patients are old at the time of surgery, if they have genetic syndromes such as Down syndrome, if they're anemic and undernourished prior to surgery, and if they need blood transfusions intraoperatively. What are some of the factors that protect against these poor outcomes? The younger the age at which the surgery is performed, the use of a protective colostomy, as our own Prof. Duncan had concluded, preoperative bowel preparation, utilization of extra tests or ancillary tests such as calretinine on the biopsy specimens to confirm the diagnosis of Hirschsprung's. And if it is that we do biopsies at the site at which we're performing our anastomosis to make sure that ganglion cells are present at the end of the day. We hypothesize that these previously stated protective factors are applicable in our research deficient setting. We aim for this study period to determine firstly the number of cases of Hirschsprung's disease that are managed at the University of the Hospital as well as the Bustamante Hospital for Children, to determine the rate at which these post-operative outcomes do occur, that is, persistent constipation, enterocolitis, and fecal incontinence, to identify which risk factors, both modifiable and non-modifiable, are associated with these outcomes, and of course, to compare our post-operative outcomes with international best practice. Our study is ongoing, it is retrospective and observational, and we're looking at children aged 0 to 15 with a histologically confirmed diagnosis of Hirschsprung's disease who have been treated by a pull-through procedure. As said, the complications which we are identifying are persistent constipation, enterocolitis, and fecal incontinence, and we'll identify these patients using ICD coding indices, operating theater records, hospital admission, and outpatient records. We expect a sample size of 80 patients. We'll be looking at patient demographics, their age, symptoms at presentation, how the diagnosis of Hirschsprung's was made, the type of surgery that they had performed, whether it's a stage procedure or a single-stage, multi-stage procedure, or a single-stage procedure, the complications that they developed, as well as how it is that these complications were investigated. We'll be using the SSPS software to analyze our data. I know this table is quite small on screen, but this is a representation of the data collection table that we are using. And I just highlighted in yellow some of the areas that we looked at, such as age of onset of symptoms, their nutritional status through the albumin level, hemoglobin level, etc. So what have we found so far? We have looked at 5 records, so we're quite early in our data collection. All of these patients had symptoms within the neonatal period. And the most common symptoms were poor feeding, abdominal distension, as we can understand, and bilious vomiting. Majority of patients were confirmed to have Hirschsprung's using an open rectal biopsy, and that's a type of procedure in which we do under general anesthesia, under direct visualization. We'll take a sample from the rectum versus a suction biopsy, which was done, is done at the bedside. And most of patients had bowel preparation prior to procedure. No patients had a protective colostomy. the hemoglobin levels preoperatively were acceptable for all patients, and we only had the albumin level recorded preoperatively for one patient, which was 40, and it's normal. 80% of patients had their surgery by age 3, and one patient had his surgery at age 16. Majority of procedures were multi-stage, that is a 2-stage Swenson's procedure, and one procedure was a single stage. So now to the meat of the matter, what have we found in terms of complications? Well, 2 patients post-operatively had Hirschsprung's associated enterocolitis. One had persistent constipation, and none of them had fecal incontinence. Of the 5 patients, one of them, we do not know what their post-operative status is, as they were lost to follow-up. Of note, the inflammation of the bowel or Hirschsprung's associated enterocolitis post-operatively was seen in the 2 patients who actually had the staged procedure, and the patient who had constipation had undergone a single stage procedure. What are some of the limitations that we have identified so far? Firstly, incorrect ICD coding of pathology. We have found that some of the patients who were actually coded as having Hirschsprung's disease have some other bowel pathology when we go through the dockets. Interestingly, Hirschsprung's associated enterocolitis. Now, I want us to understand that this has very similar features to gastroenteritis. And in fact, one of the patients who we have reviewed so far, she actually presented to accident and emergency at least 2 times with symptoms suggestive of gastroenteritis, and was discharged when in fact it could have been Hirschsprung's associated enterocolitis. So this confounder may actually underestimate the amount of cases of a Hirschsprung's associated enterocolitis that we see. So finally, what is it that we hope to achieve with our study? In our predominantly Afro-Caribbean population, we want to risk stratify our patients. We want to provide preoperative risk reduction strategies using the data that is provided, so we can decrease the post-operative complication rates and, of course, improve the quality of life for these babies. To streamline preoperative investigation and preparation of patients, and of course, increase the awareness of Hirschsprung's disease in the local media and scientific communities, and facilitate benchmarking of local post-operative outcomes to international standards. These are my references. Thank you.
Thanks, Dr. Christian. Are there any questions?
Lots. So let's start.
Yes.
Dr. Christian?
Yes, sir.
I'm still confused as to your endpoints.
Mm-hmm.
You said, and I quote, the rate of complications, and you list about 3, constipation, HEC, and so on.
Mm-hmm.
But I don't see where in your methods you're collecting a rate. So define for me what you mean by the rate of complication, because I still don't get it.
Right, understood. Thank you, sir. I believe correct term is not rate. So we'd want to determine the number of patients with those complications. So not rate.
You want to confuse people like me. All right, so that's number 1.
Yes.
All right. So what is your endpoint to count those complications post-surgery? Is it 1 month, 2 months, 1 year, 10 years? I don't know.
Yes, thank you as well for that question. So in going through the literature so far, I would want to stop at the point where the patients are actually discharged from the clinic. We don't see patients usually by age 16. That is a cutoff time period at UWI. At Bustamante is age 12. So we'll be following up the patients until that time.
So then you still have to then define your endpoints precisely. Is it the first occurrence of the endpoint? Is it the number of times that that endpoint is recorded in the docket until the close of follow-up? I'm still unclear.
Okay, understood, sir. The endpoint would be up until we stop following them, and then the number of times each. For example, with Hirschsprung's associated enterocolitis, the number of times that they present with that.
Okay, all right. And then my final question relates to one of the characteristics that you want to do, the attributes of your patients that you're looking for.
Mhm.
You mentioned nutritional status.
Yes.
And then following that, you mentioned albumin level. So then you're asking them a question now, how well is albumin a measure of nutritional status? And you only had it in 1 out of 5.
Well, with regards to the nutritional status, the marker that we would be using is the albumin level, because given that this is a retrospective study and observational, I think anything else that we decide may not be something that is documented across the board in every set of notes. Apart from a child looking well, described as well looking, adequately nourished, all those things are subjective. The only objective measure that I can identify so far as a marker for how well they are nourished is the albumin level.
And I will posit that as a very poor marker. I would suggest that you probably think about weight and length or something like that rather than albumin.
Okay. Mhm.
Thank you, Dr. Christian.
Thank you.
Well, following up on Prof. Reed, my
Mhm.
simple question, you said you had a sample size of 80.
Yes.
Why 80? How did you come about with that number?
So that's the expected sample size based on the collection table that I've received based on the ICD codings from the 2 hospitals so far. And I said, a limitation that I've noticed thus far is that even though they're coded as Hirschsprungs, when you go through the docket, they have something else like anorectal malformation. So it's really based on that sheet that I've received by both hospitals. I estimate that as my sample size.
Okay, so you didn't calculate your sample size based on the literature?
Pardon?
You didn't calculate your sample size based on the literature that is existing?
No, I calculated it based on firstly, before even getting the listing from the different hospitals, the number of cases that, based on discussion with other colleagues and so on, that we would have expected to see over this time period. And then that was corroborated with what I got on the listing from both hospitals.
All the cases that were presented. So it was all the cases you heard. Or were there some left out?
No. So the 5 that I went through,
I didn't know the 80.
oh, no, that's.
Dr.
based on
Soares, you
the
can
study.
ask private questions over there, you
No,
know.
I'm here with you when I'm trying to set down our blood pressure. You all are really formidable for some of them.
Yeah, man.
All right,
So the 80, does the 80 represent
Mhm.
all of the cases that you found during the time period for both hospitals?
Based on the listing, yes.
Okay, so basically what you did was a census, that's what we call it.
Okay. Okay, thank you. Mhm.
Hey, Dr. Bradshaw, thanks for the presentation. I do realize that you're going to have a numbers challenge. You know, I really can't determine much from the 5.
Right.
Looking at the 5, it looks like almost all of your patients are going to have some complications.
Right.
So how are you really doing with this population of patients as a hospital or as a country? That's my first question.
Mhm.
And maybe before you answer that one, I was trying to figure out if you actually have done all the records from 2013 to 2023.
Yes.
You've searched all of those?
No.
About
Still ongoing.
So you,
Mhm.
so that 5 is from about how many years?
That 5, this spanned the years. So I didn't do it in order like 2020, 2013, then 2014, and so on. I just started taking dockets and going through, to
Okay.
be frank.
So I
Mhm.
was just wondering how realistic it is for you to meet even anywhere near the numbers that you want.
Mhm.
And so in the end, you may need to kind of think through the objectives that you are going to actually write up.
Right.
But yes, if you could answer that question in terms of how well we're doing with these patients, because it looks like they're all going to have complications, 100%.
Okay, so thank you for that question. No, they don't all have complications. I can say 1 out of the 5. So 2 had enterocolitis, 1 had persistent constipation, 1 we didn't know about, but 1 was fine. So off the top of my head, I think why this study spoke to me or stood out to me as well is that the ones that you will remember are the ones with problems. And that doesn't necessarily mean that most of them have problems, but we really, as a pediatric surgery body, need to take stock and see what's happening with the patients in the post-operative period. But I think for the most part, a lot of our patients are doing well.
Okay. Thank you very much, Dr. Christian. So next up, we have Dr. Katragadda. He's going to be telling us a bit about multiple sclerosis. He's one of ours in radiology. And here you go, take it away, Doc.
Thank you, Dr. Soares. Good afternoon, everybody. My name is Dr. Katragadda, and I'll be prevalence of multiple sclerosis in an Afro-Caribbean population of patients. This is my outline. Let's get into the background introduction. Multiple sclerosis affects approximately 2.5 million people globally, as reported by Dendrell Fugger et al. It is the most common amongst the spectrum of central nervous system inflammatory demyelinating diseases. Literature speaking directly to the Caribbean region, more specifically Jamaica, is limited. The pathogenesis of the disease can be briefly explained as inflammation in localized areas of the central nervous system, attacking myelinated axons, resulting in demyelination and subsequent axonal loss. This neurological deterioration that results is usually detected due to cognitive and physiological symptomatology, which leads to further exploration via magnetic resonance imaging. As I had said before, the disease results in multiple sharply demarcated lesions of variable sizes with a random distribution in the CNS. They are most dramatic in the white matter of the cerebrum, with some propensity for the white matter abutting the lateral surfaces of the lateral ventricles. Observation of these lesions is done to greatest advantage via MRI, and MRI scans have been proven to be suitable for diagnosing and monitoring disease activity. And it's one of the key elements utilized in the McDonald's criteria for the diagnosis of MS, along with dissemination in space, dissemination in time, and clinical attacks. There's several risk factors associated with increased incidence of multiple sclerosis. These include sex, genetic predisposition, race, and environmental factors. The prevalence of MS has not been well documented in Jamaica or the rest of the Caribbean. But overall, sparse data available on the prevalence of MS in the Latin Americas and the Caribbean demonstrates prevalence rates between 0.08 to 0.2%. One study by Risco et al., consisting of a review of 10 studies done in 6 Latin American countries between 1991 to 2007, demonstrated a prevalence of 0.75 to 21.5 per 100,000 cases. Another study by Melcon et al. Had data on 30 prevalence studies from 15 countries, and it revealed a prevalence of 10 cases per 100,000 in Cuba, the closest Caribbean neighbor of Jamaica. Our hypothesis for this study was that the prevalence in our Afro-Caribbean population is comparable to figures commonly reported in the literature. The aims of this research included the option to explore prevalence of multiple sclerosis in patients who completed MRI brain scans at the University Hospital of the West Indies from 2019 to 2023, and to compare our prevalence with prevalence in other geographic distributions. Our methodology. A retrospective review was done using data derived from the UHWI picture archiving and communication system. This database was used to identify the patients who underwent an MRI brain scan with an indication related to the diagnosis of MS. Review of the imaging findings and reports was done by 2 consultant radiologists with a combined experience of 40 years to confirm the diagnosis and pattern of multiple sclerosis. A review of the notations provided by the referring physicians detailing the patient's symptoms was also done. Our inclusion criteria was patients over the age of 18 who presented to our department for an MRI brain, and patients who had diagnostic quality sequences corresponding to a MS MRI brain protocol scan. We excluded patients under the age of 18 or patients with incomplete or suboptimal scans. Data collection was followed by statistical analysis utilizing SPSS. And our preliminary data has shown that the sample comprised of 1,078 patient scans with ages of patients ranging from 18 to 92 years. The mean age of the patients involved in the study was 52 years, and the 5-year prevalence was documented at 1.5%. So 16 positive cases of MS over 5 years. This is a pie chart showing our prevalence. The positive cases is in dark blue, 1.5%. This is a pie chart showing the sex distribution of positive cases. As you can see, the light blue portion of the pie chart is the female gender with respect to the positive cases, and about 69% of the positive cases were female. This is a bar graph demonstrating the parish of distribution for the positive cases, and as you can see, 81% of the positive cases were from the Kingston-St. Andrew area. Data analysis is still in progress. However, based on what we have so far, we can say that the studies previously mentioned before in Latin America and the Caribbean demonstrated prevalences of 0.075 to 0.02%. And according to other studies done by Kister et al. And Langer-Gould et al. In the US, people with African ancestry were found to have a prevalence of around 0.2%. Our study demonstrated a prevalence of 1.5%, which was higher than those studies. Some limitations with this study: there are a small number of positive cases. Our sample size was also small. There are also barriers to imaging in terms of affordability and availability. The study was conducted at the University Hospital of the West Indies, which could also lead to a possible selection bias. And the majority of the time frame for the study occurred during the COVID pandemic. That may have deterred patients from health-seeking behavior, attending clinic, and going for their MRI scans. So our study demonstrated a prevalence of 1.5%, which was higher than other studies in the Caribbean and Latin America. An example is a 20-year study that concluded in 2011 revealed a prevalence of 10 cases per 100,000 in Cuba. With respect to the females being disproportionately affected, several studies have shown that there's a 3-to-1 ratio of females to males being affected by MS. And this study had a similar distribution with 69% of the positive cases being female. How do we move forward with this data? Well, patients in other regions, i.e. Central and Western Jamaica, could be reviewed to add to our current body of knowledge. And a prospective study at our center in collaboration with the Department of Medicine Neurology may also be useful. These are my references. Thank you.
Thanks, Dr. Katragadda. Okay, Prof is ready.
All right, so the first question I want to ask you is, in your definition of MS, you told us that it's a combination of several factors, clinical factors in terms of times and symptoms and space, as well as radiological imaging, all right? So the question I have to ask you now, because your presentation is strictly on radiology, is what is the specificity of MRI in diagnosing MS?
Well, sir, I don't have the percentage available to me, but it in conjunction with clinical attacks as well as the MRI and
Right, so I got that from your introduction. So,
yes.
But you're presenting to me a finding that is exclusively radiological.
Yes.
And you are brave enough to say that those findings that you see on radiology suggest that these patients definitively have MS, because that's what you're saying.
Well,
so my question then is, what is the specificity of this diagnostic modality in diagnosing MS?
Well, sir, the MRI is superior for demonstrating the lesions that are evident in patients with MS. However, it's used in conjunction with the other parameters of the
did you have the other parameters for your positive cases?
Based on the clinical annotations that were on the cards provided, sir, the diagnosis of MS was made in conjunction with that as well.
Okay, that was not quite clear.
Okay. Sir.
Okay. All right. So in which case then my other question would then be moved. So let's move over to.
Okay, thank you for your presentation. Okay, I just wondered, just following that, what you did, you gave us some results, but what kind of analyses did you do? What was your statistical analysis? How did you distribute your data, all of those things?
In terms of, can you repeat the question, ma'am?
What was your statistical analysis plan? What did you do to get your results?
So essentially, the data that we collected included the patient's age, their gender. Most of our patients are Afro-Caribbean, so delineating race would be difficult. The other parameters that we used were the dates that the patients did the scan and their addresses.
Okay, so what did you do with those variables? That's the question I'm asking.
Essentially, we just documented the numbers and then we put the numbers forward and moving forward with the research because we're still continuing the analysis. We just wanted to compare those findings to other findings in other geographic distributions.
Okay, so my final question. You found a higher prevalence than what is existent in the literature. How do you interpret that?
Well, I'm kind of gonna say that with respect to that, this is the University Hospital of the West Indies. Our sample size was 1,078. That sample size is much smaller than the sample size utilized in the other studies. This is a type A care center. So patients with multiple sclerosis would eventually find their way here. So that could explain why the prevalence rate was higher at the university. Including data from Central and Western Jamaica would be useful, and having a higher sample size would also, I think, be better for determining an actual prevalence rate. Sir, Professor, sir, with respect to the specificity of MRI for finding these lesions, it's about 99%. Yes. Repeat, sir?
How would you be discordant, reported, or classification by a two consultant? Or did your consultant just be all the time?
They came to a conclusion together, sir, because it was a review done together. And they basically agreed when they saw the cases. It was pretty point blank. The specificity of MRI is 99%. And then the clinical annotations along with that clinch the diagnosis.
All right. Oh, no.
Yeah,
question from
we're
me.
running out of time for questions for him, and I'm worried about keeping the IT people here late. So that's what is driving me. What's your question, please, Prof?
I just wondered how he determined the Afro-Caribbean because I didn't see that really discussed.
This was just poetic license because most of our patients are of that extraction, and using statin, our population is over 90% African extraction at the hospital. I've done that on previous studies, so we just ran with that. We thought that was an acceptable thing to say. Go ahead. Well, it's your first one. Go ahead, let me hear. You don't want to come up here. Yeah,
Thank you for that presentation. So my question is, I'm not sure about the sample. I thought I heard you say that these patients were patients suspected of having MS. If that is the case, then is it really a prevalence in the Afro-Caribbean population, or is it a prevalence in patients suspected of having MS? Because was it that you reviewed all MRIs of the brain, or was it that you only reviewed MRIs of persons suspected of having MS, referred with a suspicion of MS?
Yes, sir, we did. We reviewed all the brains. So 1,078 brains were reviewed.
Okay.
And for our non-radiology colleagues, the findings at MR are quite striking. So we don't call unless we see. And the specificity, as he said, is in excess of 95%. So thanks, Dr. Katragadda. Thanks, judges. So we're getting some good discussion. So thanks, presenters. You're not putting them to sleep. You're engaging them. Excellent. So next we have Dr. Gore, who is going to be giving us some interesting insights into boarding time in the emergency department.
Good afternoon, everybody. My name is Sujay Gore. I'm a fourth-year postgrad resident of emergency medicine. With my supervisor, I'm glad to present my research topic, is increased boarding time in the emergency room of an urban hospital associated with an increase in hospital mortality and length of stay. So initially, during our literature review, we noticed that boarding time had different definitions from articles to articles. So the American College of Emergency Physicians defines boarding time as the time remaining in the emergency room after being admitted or being placed into observation status. Schaffen et al. In 2007 noticed boarding time longer than 6 hours significantly increased adverse effects on the patients that were admitted. Mortality increased from 2.5 in patients less than 2 hours to 4.5% in patients more than 12 hours. And that was documented in Singer et al. In 2011. Sun et al. In 2013 noticed that boarding time resulted in a 5% greater risk for in-hospital mortality for patients with longer hospital stays. In our literature review, we noticed that there was no literature observing this phenomenon within the country or within the region. So we thought that our aim for the study was to investigate the relationship between increased boarding time and in-hospital mortality and length of stay in admitted patients in the University Hospital of the West Indies in Mona, Jamaica. Our objectives were two. The primary objective was to analyze the data to determine the influence of boarding times on in-hospital mortality and length of stay. And our secondary objective was to find a boarding time limit that was associated with significant increase in mortality and length of stay. So our methodology, it was a single center, retrospective cross-sectional study where review of the charts were done between the patients that were admitted between January of 2024 to June of 2024. When our sample size was reached, the study was terminated. What did we do? Our daily logs included demographics, time of admission, specialty that they were admitted to, time patients were transferred to the ward, discharge time, and plus or minus if somebody in hospital mortality. Our exclusion criteria included patients transferred for admission from an outside hospital, patients seen in the pediatric or gynecology and obstetrics ambulatory units, our psychiatric patients, and patients who had missed data. This was a statistical analysis that we used, which include descriptive statistics, multivariate logistic regression, cross-tabulation with chi-square testing association. So this is a table showing the basic characteristics of our study population. We noticed the mean age of all the patients that were admitted to the emergency department was 61.91 years. It was predominantly female at 60.4%. Admitting specialties, 82.4% was internal medicine, 10.4% was general surgery, and 7.2% were the other subspecialties. The mean length of stay means from triage to the time of discharge, was 516 hours, which was pretty much more or less 21.5 days. Mean boarding time, however, was 64.06 hours, which is about 2.7 days. Disposition outcomes. Persons who died in hospital were 41, which accounted for 11% of our sample size, and discharge was 333, which was 89% of our sample size. So when we looked at our data, we noticed something quite interesting. 92% of our patients who were admitted in our emergency department spent more than 10 hours, and 44% of the persons admitted spent more than 50 hours within the emergency department. That's about 2 or more days. So we compared in-hospital mortality with the different boarding time groups. So this table has our admissions by boarding time groups at the bottom, less than 10 hours, 10 to 20, 20 to 30. Green represents discharge, and orange represents in-hospital mortality. As you can see, by the time they reached 30 to 40 hours, there was a 24.39% mortality rate for patients admitted 30 to 40, 10.5% of persons admitted 40 to 50, and 12.73% of persons more than 50 hours. there's a big jump from 20 to 30 to 30 to 40. This bar graph shows with a 95% error bars shows the mean length of stay being time persons was at triage to the time they were discharged. And we can see there's a significant increase, or in comparison to persons less than 10 hours, there's a big difference between is an increase. As the time progresses, the longer persons stay in hospital. So we went ahead and did our statistical associations. And we noticed in a population, when we separated them in between boarding time groups, of the 41 persons that died, we noticed when we did our chi-square testing, it was statistically significant with a p-value of 0.017. And of this, we noticed 51% of persons who died in hospital spent more than 50 hours in hospital. It's 50 hours in the emergency department, I'm sorry. 75% of persons who died in hospital spent more than 30 hours in the emergency department. So we went ahead and did a chi-square testing to recognize the association between the different age groups and mortality, which was also statistically significant with a p-value of less than 0.01. And we can see here that of the 41 persons who died in hospital, 78% of those persons were more than or equal to 65 years old. So the association is, as the persons who are old in the emergency department, they more have an increased likelihood of dying in hospital, sorry. So we went ahead and did a logistic regression for association between in-hospital mortality rate and boarding time adjusted for age, sex, and ESI. ESI is Emergency Severity Index. And we notice what's highlighted here, that persons who stayed in the emergency department between 31 to 40 hours, they did have a significant association at a significance of 0.046. Others didn't show that much, but between that time bracket showed a significance of 0.046. This is just a graphical representation of what was shown in the table prior. So when we did the odds ratio of mortality between the age groups, persons who stayed between 30 to 40, in comparison to persons who boarded less than 10 hours, there was a 5.9 odds ratio more in comparison to persons that spent less than 10 hours in the emergency department for mortality. So after that, we went ahead and did our Kruskal-Wallis test to compare the comparison of median length of stay in hospital between the different age groups or the different boarding time groups. This p-value was not statistically significant at a value of 0.101. Then we went ahead and we did a comparison, same Kruskal-Wallis test between the different age groups and the mean length of stay within hospital. And we noticed that was statistically significant with a p-value of 0.09%, sorry. They just show that the median length of stay, when we look at our graph, 45 to 64 and more than 65, it goes from 150, 127 in comparison to persons who stayed in hospital who were aged 0 to 17 years. So in conclusion, 44% of admitted patients spent more than 2 days in the emergency department. The mean boarding time was 64.06 hours, which are more or less about 2.7 days. 75% of in-hospital mortality was associated with more than 30 hours of boarding in the emergency department. Our odds ratio of 30 to 40 in comparison to persons who spent less than 10 hours was a 5.1 to 5.9. Elderly patients with increased boarding time have a statistical positive association with in-hospital mortality, and older patients were noted to have an increased boarding time, resulting in increased length of stay in hospital. These are my references for the studies I said in my talk.
Thanks, Dr. Gore. Any questions?
All right, so a couple quick ones. Yes, sir. So first thing first, nowhere in your slide I saw where your ends were. And all your results slide, I didn't see what your ends, your numbers, your counts. So I can't make an assessment of what those numbers mean because I don't know what your ends are. So that's number one.
Okay.
Yeah, go ahead.
So you want me to say the total sample size?
No, the sample, what? The sample size for any of the analysis that you did. I have no idea what they were.
So the whole sample size of the study was 374.
Yes.
Right? Of each, you can go back. So especially in this graph, it shows in-hospital mortality was 41, and in brackets is the amount of persons, numbers, and in outer brackets are the percentages.
Yeah, man. So that's 21 people who died. Out of how many?
It's 374.
Yeah,
so
but
that was initially.
Raise it on the slide.
Sorry, so initially I did say discharge was 333. and in-hospital mortality was 41. Pardon me?
Okay,
Sorry, if I didn't put it on other slides, I apologize.
okay, all right, so that's where you put it.
Yes, sir.
The other big question I have for you is, you said that in your logistic regression.
Yes, sir.
One of the issues why the sample size is important, because you're doing this retrospectively,
yes,
it doesn't mean that all the points are you're going to have data for all the points. And so for somebody like myself who is looking, we're going to be saying, okay, did you have any missing data? I don't know if you have any missing data because you don't put the ends for any of the things that you were doing.
Understood, sir.
The issue now is that you then presented your story in a, what we call up and down way. So essentially you had a set of predictors that you wanted to predict an outcome, and you built us up nicely to say that these predictors may be important. You then showed us what the outcome is by doing the logistics. And then you went back to repeat yourself, but just repeating yourself in another way.
Fine.
So the last two slides that you did with the critical Wallace and all, those are redundant. So they really have no bearing on this at all.
Okay.
All right.
Okay, sorry. Thank you so much for your presentation. Just one quick question. Did what the person presented with in ER, was that taken into account?
So thank you for that question. So initially what's not represented here were one, the diagnosis, and two, the emergency severity index. And also what we experimented in this study was something called the rapid emergency markers. And that took in account of all of their vital signs, including the blood pressures, heart rates, the vital signs, their initial GCS, and that pretty much categorized them as same. I didn't present it in this presentation, but yes, when we collected our data, we did both the diagnosis, the emergency severity index, which is a triage, where we triage our patients, and a rapid emergency marker, which did show some association.
So adding to that, wouldn't you have expected those to impact the correlation?
So that's why we did logistic regression, to try to isolate that from all of it. Even when we did our studies though, we did notice that ESI, which is the emergency severity index, and our rapid emergency markers did have positive statistical association with in-hospital mortality.
Okay, so you will be doing a model to adjust for all of those confounders.
Of course.
Prof. Aiken has a comment.
And change policy. A study like this can set guidelines and policy. So I really want to congratulate you on doing this study.
We're kind of behind time. We've managed to lose 15 minutes. Next up is Dr. Akeem Smith. Unfortunately, Dr. Ingram won't be able to join us. And I mentioned Dr. Chambers as well. There's an abstract for him, but he couldn't join us either. And you all might see some posters on the walls and outside and near to the museum. These are we're revisiting posters that were shared at the FMS Annual Research Conference, for those of you who didn't get to have a look at them. So Dr. Akeem Smith is from the Division of Orthopedics, has some interesting stuff to tell us about cannabis and fractures. Unfortunately, his name is not in the lineup, but his abstract is in the program. It's the one on zebrafish.
All right, good afternoon, everyone. I'd like to do a presentation on behalf of the Department of Orthopedics entitled The Effect of Cannabis Extracts on Fracture Healing using a zebrafish model. And my primary investigators are Dr. Wayne Palmer and Dr. Mohammed Ali from the Department of Basic Medical Sciences. So this is the outline which I'll follow today. So in terms of the topic, the therapeutic potential of cannabis has garnered renewed interest over the past 2 decades. However, the literature presents conflicting evidence regarding the health benefits of cannabis extracts, particularly concerning the effects on bone growth. This study aims to elucidate the impact of different cannabis extracts on bone healing and regeneration in the adult zebrafish following caudal fin fractures and amputation. So in terms of some background, worldwide, there's approximately 178 million fractures per year. And in North America, they estimate approximately 2 million, and that costs them approximately 2.5 billion per year. Unfortunately, 10% of these fractures can undergo a complication, whether it be a non-union, pain, or some sort of dysfunction. As such, there's been renewed evidence to insight some sort of novel therapeutics to see how we can enhance fracture healing to offset these symptoms and signs. And so there's been a growing need for another basis in which we can investigate this outside of human models. So this brings me to the topic of the zebrafish. So these are some small Teloise fish, as you can see the size there. And you're probably wondering, how can these really help us? So they're not new. They've been studied since the 1990s, with the biggest research being done in Oregon University in the United States. And remarkably, these fish, they exhibit 88% of similar genes to human beings. So they're quite social, and they can be reproduced. Here you can see, if you follow the dotted white line, you could actually amputate the fin and it regrows and exhibits similar bone healing as in humans, where we have callus formation, so-called enchondral ossification. The aim of the study was to determine the effects of variants of cannabis sativa, specifically THC, CBD, cannabidiol, and the aromatic compounds mixed with cannabis, the so-called terpenes. And how does this affect bone healing and the caudal fin regeneration in zebrafish? The hypothesis was that the CBD extract should accelerate the rate of the caudal fin regeneration and actually increase the bone thickness of the caudal fin. So this was an experimental study in Nature conducted last year, October, and it's still ongoing in the Department of Biochemistry. Ethical approval was obtained by the MERC at UWI. So in terms of how the experiment was done, we divided into 4 groups of 10 to 12 fish. One was unexposed, we call a control group, then those exposed to CBD, THC, and then terpenes. What we did was we formed different baths with the fish exposed to similar diet, etc. And then we induced a fracture in the fin, amputated distal to the fracture site, and then watch the regrowth over time at day 1, day 5, day 10, and day 15. They actually reach full regrowth or maturation in 2 weeks, contrary to human beings 6 weeks. So here you can see just a picture showing when we actually remove the fish from the bath. They're examined alive, given local anesthetic. The blue lines, if you can see here, along here is uptake by methylene blue. And then we amputate distal to the fracture site and then watch it regrows over 2 weeks and measure same at the intervals. So the inclusion criteria included a healthy adult zebrafish. They attain maturation at 6 months. They would have had to undergo the same diet, right? A similar fracture method has to be induced and similar pattern, right? We excluded any previously injured fish. And if we excluded fish with any illness and any that was previously exposed to local anesthetic. This is our data analysis so far. Here you can see some graphical representation. The overall sample size was 48, and here you can actually see the percentage regeneration of the fin on the left on the y-axis, and then the different groups on the x-axis. This represents a plot where you see the day 5, day 10, and day 15. And here you can see that in the control group, they attained almost near full regeneration at day 15. However, you can see a decline in the other compounds. The label at the top indicates where we measured on the fin. We divided it into 3 groups on the fin itself, so we could get a more robust outcome. So this was the measurement at the top. This was the middle. and then at the lower aspect. So in terms of our analysis, we use the ANOVA F test since it was more than 3 groups. And we also did the T test. And here you can just see comparison within the groups, whether or not the tail is growing. And it was actually significant amongst all groups, as you can see the p-values here. Here we had actually analyzed the data at day 5, day 10, and day 15, comparing the control with the THC group, THC with CBD and CBD with terpenes. And you can see remarkably that at day 5, they were statistically significant, marginally significant at day 10, and also significant at day 15. And overall, the most significant was that of the CBD group versus the terpenes. We also looked at the fracture characteristics. Here you can see a normal virgin fin. We stain it with a dye called alzarin dye, and alzarin binds to calcium, and it can show the uptake in the fin. We then went on to fracture the fin and then look at it for the different groups. And here you can see the thickness actually increases after you've induced a fracture. So this is the control group here. And then here you can see the THC group. And then the CBD group had the greatest thickness after inducing a fracture. So overall, what they showed was that the THC treatment resulted in significant concentration-dependent reductions in the regeneration compared to the treatment, the control group. However, the THC morphology showed more dense deposition with greater fin thickness than the control, but less compared to the CBD group. Other studies have corroborated this, specifically that by Keith et al., where they actually show mixed effect of THC on bone healing. Kim et al. And Kogan et al. Has also shown positive effects of THC and CBD on bone healing. The CBD effect, however, noted that there was also a decrease. However, it was more significant compared to the THC group. Overall, the regenerate bone exposed to THC and CBD showed marked increase in thickness, density, and staining, correlating with increased calcium deposition. The limitations of the study include the fracture pattern, the uptake by the fish, the rapid turnover due to the rapid time healing compared to humans, and also observer bias. So in concluding, the observed growth inhibition associated with THC and CBD extract aligns with existing literature. However, the THC-treated group demonstrated comparatively less inhibition than the CBD-treated group, challenging some prevailing assumptions in the field. The CBD group showed the greatest increase in thickness, which would indicate that it has a greater effect on oppositional growth, the so-called width or density of the growth, as opposed to longitudinal growth. This gave the overall impression from the study that the THC and CBD group exposed extracts, they had a greater qualitative than quantitative effect on bone healing and caudal fin regeneration using the zebrafish model. All right, and just to conclude, this can actually go on. Once we've done this type of study, we can go to validating mammals and then go on into human trials. Thank you, and these are my references.
Thanks, Dr. Smith. Glad you got to escape from theater. Any questions?
All right, so essentially then, Dr. Smith, what you're saying is that the ganja people, they took long to heal, but they healed with stronger bones.
Correct.
All right. All right, a couple of quick ones I just have for you then. You used about 20 fishes in the analysis based on what you
We used 12 fish in each group.
12 fish in each group,
Yes.
Okay. All right. How did you do control for multiple comparisons?
What did we do?
Control for multiple comparisons.
Oh, okay.
Because you did multiple t-tests, you did all kind of funny stuff. So how do you control for multiple comparisons?
Well, what we did was, so the test, we actually had to repeat the experiment about 3 times. What had happened was that the toxicity of the THC and CBD had resulted in 1 or 2 of fish being lost. So at those intervals, we had done the comparison of each group with the control and see if those are actually repeated in each study. So that was how we had done the comparative for those retrospectively.
Okay, thank you for your presentation. My question, you didn't mention what concentration of the cannabinoids did you use in each of the?
Okay, so for the concentration, we initially started with 0.005 milligram per mil, based on the attenuation purity factor being 98%. The compounds we use are from the Department of Life Sciences, Professor Emmanuel. So we had started at that dilution. However, we noted that there was significant toxicity with same. So we had to dilute it to a ratio again of 2 dilutions, 1 in 10. So essentially the concentration would have been reduced to 5 times 10 to the minus 4 milligram per mil.
Okay, and my final question, considering the synergistic effects of your cannabinoids,
Yes.
did you think of combining all 3 and doing another group?
Yes.
To
So,
see?
yes. So in terms of future prospects, that was initially a consideration. However, given the novelty of the study, we wanted to start with individualized group first, and then we want to go on to the synergism, and then we can test against our agonists and antagonists to see if it's actually significant.
Thanks, Dr. Smith. So my question is along the line of the extracts or whatever you're working with. Was it pure compounds or was it the actual extract from plants?
It was the actual extract from plants.
So how did you confirm extracts that only have CBD, only have THC, only have terpenes?
Okay, so the extracts that we use, they have a HPLC monitor, which actually monitors and divides. So it gives a reading of the different compounds and their percentage concentration in the overall compound. So that was what we had used to extrapolate with the HPLC monitor.
But as a chemist, I challenge what you are working with.
Yes.
And really what it may have been is THC rich or CBD rich or terpenes, not pure extracts. So there's some confounders there in terms of working with extracts and the compounds you're interested in.
I agree.
Okay, thank you, Dr. Smith. And just a reminder to the presenters, we're very grateful to the judges. We have a lot of experience and skills sets at our disposal, and they're here to sharpen your projects and your wits. So don't take it personally, don't feel upset. They took their time to come to facilitate you. Thanks again, judges. So next up, we have Dr. Lorianne Lee. So she's gonna speak to us about customer satisfaction.
Okay, pleasant good afternoon to you, my esteemed colleagues. I'm Dr. Lorianne Lee. I'm a final year resident in the DM Emergency Medicine program, and my research today is on patient satisfaction with customer service delivery in the emergency department here at the university. My supervisor is Dr. Eric Williams. Now, the emergency department is the face of the hospital. It is what forms the public's perception of the quality as well as the functioning of our healthcare services. It's therefore important that we analyze patient satisfaction with customer service delivery in the emergency department, as this impacts patients' compliance with their medication as well as the treatments we've instituted, the likelihood that they will make liability claims, the utilization of healthcare services, as well as whether they'll recommend us or refer us to their friends and family. Now, the university understands this principle, and hence there is mandatory customer service training for all levels of staff through the Human Resource Department. There have been previous studies overseas which have revealed high satisfaction of customer service delivery. However, there has been no local evidence-based study to assess the perception of customer service as well as patient satisfaction. My aim, therefore, was to to assess patient satisfaction of customer service delivery with specific objectives to identify factors which will impact on patient satisfaction using a valid tool, also to assess whether demographics such as age, gender, educational level will impact patient satisfaction. Based on these results, we wanted to suggest interventions which could improve customer service delivery and overall patient experience. So this was a descriptive cross-sectional study. This was a descriptional cross-sectional study of patients across all triage levels from March 1st of last year to May 31st. Patients were randomly selected by a trained research assistant every other day of the week. Using odds logistic regression, we calculated a sample size of at least 340, and then we assumed that we would potentially get a non-response rate of 20%, and hence the target population was 408 respondents. Our inclusion criteria included all patients who presented during the study period once they had finished registration as well as initial assessment. So the flow was patients would be registered. They would then be triaged using our emergency severity index, which is shown at the right of your screen. This is a 5-tier triage system where patients are stratified, according to the acuity of their presentation. So ESI 1 are patients who have immediate life-threatening illnesses and need immediate life-saving intervention. ESI level 2 patients are patients who are deemed to be high risk. They may be confused, lethargic, disoriented, or in severe pain, and they should not wait to be seen. Patients at ESI levels 3, 4, and 5 are those who have normal vital signs and then are determined based on a number of resources that we would need in order to assess and manage the patients. So a patient who is designated at ESI level 3 is a patient who has normal vital signs but needs numerous resources. A patient who is an ESI level 4 has normal vital signs but just needs one resource, and a patient at ESI level 4 has normal vital signs and does not require any resources. After the patients were triaged, they then had their initial assessment, and then they were approached for the questionnaire while they were awaiting their disposition. The exclusion criteria, we excluded patients who were under 18 years old and were deemed otherwise, who did not have the capacity, to give consent. So those included patients who had major head trauma. They were psychiatric patients, too ill to complete the questionnaire, or they were intoxicated. We also excluded patients who registered only for radiological investigations and those who had represented within 72 hours post-discharge. Our data was collected into 2 parts. Part A being the demographics of the patients, and then Part B, we used an externally validated tool called a brief emergency department patient satisfaction scale. This is a 4-point Likert scale where patients were asked 20 questions and they were asked to give a response, 1 being completely disagree, 2 mildly disagree, 3 mildly agree, and 4 completely agree. Now the questionnaire is divided into 4 categories. They assess ED staff satisfaction, ED environment, physician care satisfaction, general patient satisfaction, and patient family satisfaction. We analyzed our quantitative and qualitative data using statistical R version 4.2.2 for questions that did have incomplete responses. That was a rate at 11 to 22%. So we got a total of 418 patients with relatively equal number of male and female respondents. 54% were female and 46% were male. We were able to get patients at all educational levels from primary all the way to tertiary, and those who had no prior visits to the emergency department or had several visits. When we analyzed our data using triage level, we found that patients at ESI levels 1 and 2 tended to be older. They also had a higher likelihood of having only a primary care education, and they had fewer visits to the emergency department. The highest number of patients were triaged to the ESI level 3 level. That is 236 patients. So looking at each parameter of our questionnaire, we first look at emergency room environment. We noticed that statistically, triage level played an important role here, as patients who were triaged to lower triage levels, meaning 3, 4, and 5, were giving us less favorable responses to questions about the ED environment. When we assess the emergency room staff to questions such as nurses relieved me of my pain well, or admission staff guided me appropriately, again, we noted that patients who were triaged to lower triage levels were giving us less favorable responses. When we assess patient care satisfaction, again, we noticed significant findings were amongst patients who were triaged to lower triage level. Questions such as the physician explained about the remainder of my treatment, the physician spent sufficient time examining me, and the physician told me about my treatment course. Patients who were triaged to lower triage areas were giving less favorable responses. In the category of general satisfaction with the emergency department, again, we noticed statistically significant values with patients who were triaged to lower triage levels. So with questions such as the waiting time before seeing the doctor was appropriate, the waiting time before admission process was appropriate, we noticed patients, again, at lower triage levels were giving lower or less favorable responses. So too for questions such as, I would recommend this hospital to my acquaintances and I'm satisfied with the quality of services in the emergency department. Again, patients with lower triage levels were giving less favorable responses. Lastly, when we assess patients about their family interaction with the emergency department to questions such as, my family was able to stay at the bedside and that the emergency room staff respected family, we got 100% favorable responses irrespective of triage level. So in conclusion, patient satisfaction was found to be independent of factors such as age, gender, and educational level. Approximately 90 to 100% of patients had positive experiences with all 5 parameters that were tested using our brief emergency department patient satisfaction questionnaire. Patients who had visited more than once, however, gave less favorable responses. And those who were analyzed, when we analyzed based on our ESI levels, we also noticed statistically less favorable responses. So our recommendations based on these results, of course, is to improve the quality of care. We wanted to suggest keeping the emergency department neat and tidy, using informational videos which would guide patients on what to expect in the emergency department and the flow of the emergency department. Of course, having appropriate provider to patient ratio, and making sure that the ED management and staff are aware of our departmental goals. The ED management should also uphold vigilance with customer service officers and setting realistic goals with the key performance indicators on items such as waiting time and turnaround times to be seen. And of course, this would require further multi-center studies island-wide. The strength of this study included that we were outside of a surge period. This is where you have a sudden increase in the number of patients presenting to the emergency department, which would have overloaded our available resources. We were able to get high responses and high quality data, which was a true reflection of the entire emergency department. We minimized selection bias by randomizing our patients, and we used an externally validated tool, which was our questionnaire. And we found that this was meaningful and relevant to the responders. We minimized response fatigue as well as eliminated limited engagement by employing a research assistant who would administer the questionnaire, as well as measurement errors from inadequate responses were also eliminated. The limitations to this study, unfortunately, this was a single center study which limits its generalization to other institutions. Likely some patients would give convenient responses. There was some incomplete data simply because it did not apply to the patient. So for instance, if they presented alone, they were not able to give a response as to whether their family was treated appropriately. Patients' feedback or suggestion was not directly obtained, and the health and marital status of patients in terms of the demographics was not included in this study. I would like to acknowledge my supervisor, Dr. Eric Williams, our statistician, Dr. Akil Baker, my research assistant, Dr. Leslie Bingham, and of course, thanks to the cooperation of the university staff. These are my references.
All right, a few observations. First is that your slide on sample size is incomplete because you didn't tell us what effect you were trying to assess by your sample size. But more fundamental to your research, though, is that you keep saying that you've used a validation tool, all right? But the truth is that you're making an assumption that this tool is going to perform the same way in your sample as it has in previous sample. But you have an opportunity to demonstrate that the tool is performing the way it should be performing, but have seen no results in your thing to tell you that it is.
Okay, we actually did have that. I had to minimize the amount of information we put on the slides.
Yes.
But we actually validated the tool here and we did a pilot study testing the questionnaire. And what we found was when we didn't analyze it based on triage level, it was performing the same way it would in other studies, meaning that patients were responding favorable to each question.
Okay, so you did a validation. What was the construct validated for the tool?
The name is escaping me at this point, sir. Sorry.
Okay. All right. The other quick question I have for you is, you presented some conclusions,
Yes, sir.
right? For which you presented no data to support those conclusions in this particular presentation. And so one of the challenges you have is that when you're condensing material from a much larger thing to a shorter thing, you have to be careful that you match them one-to-one. So if you're going to, I know you want to say, conclusion A or conclusion B, you need to ensure that at least the audience have the benefit of knowing what that data is. You know it, we don't know it. All right, but you had 4 conclusions, but I didn't see any data to support all of those 4 conclusions.
Okay, I thought I presented the data. Thank you for your question, sir. I thought I had presented the data in the results, but I must be mistaken.
Thanks again for your presentation. At what time point, I may have missed it, at what time point was the questionnaire administered?
So it was after the patients had been registered, triaged, and then they had gone through their initial assessment. While they were awaiting their disposition, they were approached by the research assistant.
Okay, and you considered pain level and everything?
Yes, we did.
before-
So after the initial assessment, this is where they're seen by an emergency room physician and then they're handed over to a nurse. They would have then they would have instructions would have been given to the nurse as to what the treatment plan would be. So one of the questions on the questionnaire actually assesses for pain level, and the patients are asked to tell us whether or not they felt that their pain level was adequately managed.
Okay. And you mentioned that you analyze qualitative data, I guess. going back to
Qualitative
that.
and quantitative data.
Right, but I didn't see any qual.
I beg your pardon?
I didn't see any qualitative data.
So we had much larger tables and I had to try to condense it as much as possible. So most of the tables that you're seeing where I highlighted only the triage level is because I chose to highlight only the statistically significant portion, but there's a large number, there was a more qualitative data there.
And last question, how was the randomization done?
So we selected every other day of the week and patients were just randomly selected after they had registered by the research assistant.
Oh.
So once they had registered, I would go through and then I would be picking patients and just randomly assigning them to the study every other day. Okay, so I would go through, so for instance, there are 2 shifts in the emergency department, morning and night shift. And in the morning shift, we would designate, say we'd need 20 patients for that day and then 20 patients on the night shift. So I would go every other patient, but if I realized that I was getting more than 20, I would wait until the night shift to pick the further 20 patients. Okay. Thank you.
All right, thanks, Dr. Lee. So next up we have, yes, please. They're under a lot of pressure. So we have Dr. Miller Brizuela, going to speak to us about motorcycle accidents in Mandeville. So you're from A&E as well, right?
I'm from Jamaica.
From Jamaica.
Thank you. Good afternoon, everyone. Okay. I am Dr. Sasha Gabe Miller-Brizuela. I'm a 4th-year resident in emergency medicine DM program at the University Hospital. My supervisor is Dr. Romaine Edwards, and I will be presenting on my research on the epidemiology of motorcycle accidents at the Mandeville Regional Hospital between January 2018 and January 2022. So in my research, it was found that the fatality rate among motorcyclists in Jamaica tripled between 2011 and 2015 and quadrupled by 2021. In that same year, 166 motorcyclists deaths were reported, representing 34% of the total road traffic deaths for that year. In the USA for 2020, it was found that motorcyclists were 28 times more likely to die compared to car occupants per vehicle miles traveled. And in the UK in that same year, it was found to be 62 times more likely. Over 50% of all road traffic deaths occurred among vulnerable road traffic users, including motorcyclists, pedestrians, and cyclists. There's a gap in the published literature on motorbike accidents in Jamaica since June 2018, and no previous study was done at the Mandeville Regional Hospital, hence my rationale. Also, I worked there for a while and I was exposed to this. There are 3 published studies on motorbike accidents in Jamaica, one by Crandon and colleagues in between 2000 and 2007. That included 270 victims, a large study including 7 hospitals by Professor Trevor McCartney, and Fletcher and colleagues conducted a study in St. Anne's Bay that was completed in June 2018, and that was the last study. So the aim of this study was to identify the demographic profiles and factors surrounding the motorcycle accidents of the victims presenting to the Mandeville Regional Hospital during the period from January 2018 to January 2022. This was a single-centered retrospective cross-sectional study. Data was taken from the medical records of all the victims that presented during this time period, and the dockets were identified by the medical records department using an ICD coding and then was reviewed by the principal investigator. Each victim that presented was given a different case number, and the relevant data was extracted using a data collection instrument. It was then stored securely and analyzed later. Analysis was done using the Statistical Package for Social Sciences version 26.0, and both descriptive and inferential statistical methods were used to analyze the data. The results of the study showed that of the between 26,910 and 41,579 patients that presented to the emergency room annually between these 4 years at the Mandeville Regional Hospital, road traffic accidents accounted for up to 2.8% of the visits, and of this, up to 39% were motorbike accident victims. A total of 644 dockets were identified by the medical records and reviewed. Of this, 185 were excluded because they did not meet the inclusion criteria, leading to, from the remaining dockets, 534 cases were identified. Now, it must be noted that the sample size does not represent the total number of patients over the 4-year period, but the number of times a new victim presented from a new accident. So we had, for example, 15%, which was 67 victims who presented for more than one accident within the time period. So the victims were principally male, representing 98%. There were young males, less than 40, particularly between the ages of 18 and 27, which was 46.6%. And majority of the victims were from Manchester. Others were from St. Elizabeth, Clarendon, and other parishes as per the table. And the riders were the victims in 90% of the cases compared to pillions. The factors associated with accidents were as reported by the victims and as documented, of course, given that it was a retrospective study, as documented by the physicians or nurses who saw the patients. So in 44% of the cases, it was reported that it was the difficult terrain, whether it was wet, slippery, or they just lost control that provoked the accident, followed by collision with a car, and also you have van and even with animals. It did not differ in terms of the time of day. The similar amounts happened during the day as compared to the night, and that was taken from 6 a.m. to 6 p.m. and 6 p.m. to 6 a.m. Accidents occurred more frequently on the weekends, 51% of the time, particularly on Saturdays, which was 19%. As per the table below, you may see that the summer months, there was a spike between May to August, and also towards the end of the year, November to January, we had more cases reported. As it relates to the wearing of helmet, the use of alcohol and marijuana, you may see different N values because being a retrospective study, documentation was poor in some instances where there was a lot of missing data. So of the known data, 87% of the victims were not wearing a helmet, 41.3% were consuming alcohol at the time, and 40% were smoking the day of the accident. The injuries were principally of the lower limbs, 67%, also the upper limbs 45%, and facial injuries 42%. 13% were chest and abdominal injuries, and 60% of the victims sustained multiple injuries. Fractures were quite common, particularly of the limbs. As it relates to specialist care involvement, 67% of these patients required specialist service or had to be followed up at the nearest health center. Orthopedics and general surgery were the most commonly referred to specialties, but as you may see on the table, multiple specialties were involved. And at least one specialist service was required by 50% of these victims. The admission rate was not elevated. 73% did not require admission. And of those that were admitted, majority spent 10 days or less. And less than 9% required surgical intervention. So the results show that the number of injuries sustained by the patients was not particularly significant in terms of not affected by the time of day or the day of the week. However, there was a weak positive association between the number of injuries and the number of specialties consulted. Similarly, the use of alcohol on the day of the accident did clinically affect the number of injuries. So there were more injuries for the patients who were consuming alcohol, and they did require more specialist involvement. However, this data was not statistically significant. Marijuana and helmet use did not have any statistical value in terms of significance, in terms of number of injuries or the length of stay of admission, nor specialist care. As it relates to the mechanism of the accidents, there is a 3% variability that accounted for the admissions, where, as you may see in the diagram, the dark shading is where the patients were admitted. And naturally, you may see those who were involved in an accident with a truck or a van had more admission than those, for example, who were involved or the accident was provoked by the terrain. The day of the week did not show any particular trend in terms of the use of alcohol or marijuana. As you may see on your left, that represents alcohol use in the dark, and the right is marijuana. More persons were drinking alcohol on a Tuesday, for example, and on the weekend, and marijuana on a Tuesday, Wednesday, and on the weekend. So happy hour is no longer on a Thursday. So in conclusion, the Mandeville Regional Hospital provides services for multiple motorbike accident victims, but no previous study was done there. The victims of this study were predominantly young, healthy males who were often consuming alcohol or marijuana and were not wearing protective gears. They sustained multiple injuries requiring specialist care. The findings, I know I did not document all the results, but I can go through afterwards to show that they were comparable to the previous studies as well as the international studies. And these accidents, the frequency and the treatment required shows that they may be a burden to the healthcare system. As for this research, we had some limitations. One in particular was that because it was retrospective, documentation was an issue, so there was a lot of missing data. Also, as it relates to alcohol and marijuana use, there were no available qualitative or quantitative studies to assess if they really were intoxicated or not. It was really what the patient said. And oftentimes they were dropped off by a police or they were intoxicated or had head injury, so we could not trust that information. Also, it was a single-centered study, so a larger study would be required for it to be considered fully generalizable. Thank you.
All right.
Thanks, Doc.
Yeah, so my question really relates to what adjustments did you make for multiple presentations by the same person?
Okay, so
could the issue is that they could be different from the rest of the people who only had one accident?
Oh, you mean to identify why they were repeat offenders?
Well, what adjustments were made in your
So what I did was as I said, each case number was given to a different presentation. I removed all the demographics.
Yeah, and so we accept all of that. So what you have done is that you denominated the number of cases that you saw, but you also presented data on the number per person level data. So what it meant, so for example, is that if Marvin Reed presented today, I'll be counted as a case. But if I presented 3 months later, you're counting me because of how you presented the data as if I'm different. Right. So my denominator is different. But my age, if you're looking at age,
is going to be, well, most of the repeat of sorry, I should not use that term. Most of the cases that presented more than once, it was not particular in the same year. Sometimes remember, it was a 4-year period. So they may not be the same age when they repeat. But
Yeah,
I
but
had,
I'm not saying what the policy was. How do you manage that process?
well, I just included them separately because I was trying to look at the age group of the persons who were participating in these activities. I didn't separate them because they were repeating.
All right.
Okay, just one brief question, and I know we're out of time. Did you have any mortality data?
We had, from all the patients I had, one died after he was transferred to KPH. No other deaths. No, in the ambulance. Right, that was another one of the limitations. I did not include the disease because they were not recorded accordingly. So this is to show the injury or the cost or the effects on the healthcare system for those who survived, really. Right?
Cheaper if you die. Thanks, Doc. So next up, we have Dr. Morgan, who is going to speak to us on the effects of COVID-19 on patients with hip fractures. He's from the Division of Orthopedic Surgery.
Good afternoon. I'm Patrick Morgan. I'm senior resident in orthopedic surgery, presenting my research project on the effects of COVID-19 pandemic on the outcomes of patients with hip fractures. All right, so we know that hip fractures represent an important cause of morbidity and mortality worldwide, with the lifetime risk estimated to be 40% in women worldwide and 13 to 22% in men. One study showed that 5.8 million disability-adjusted life years as a measure of disease morbidity was lost in 1 year with the number of patients with hip fractures worldwide. Global Burden of Disease Fracture Collaborators study noted across 204 countries, there's a greater than 90% increase in the number of patients with hip fractures since 1990. The worldwide 1-year mortality after surgical intervention is reported to be about 18 to 33%, and surgery within 48 hours decreases mortality by about 20%. Locally, Vaughan et al. Estimated approximately 127 patients with femoral neck fractures presenting between 2004 to 2006. Dr. McDowell et al. Published a study showing a reduction in his mortality to 4.5% at the St. Anne's Bay Hospital in the inpatient mortality between 2006 to 2008 after measures that he implemented. We know that COVID-19 was declared a pandemic in March 2020. The first case was in Jamaica was in March 2020. Since then, there's been more than 150,000 cases, more than 3,000 deaths. Long COVID was said to be present in more than 80% of patients infected at the time, with significant symptoms, including fatigue, headache, dyspnea, which may affect the morbidity and outcome of our patients. There were also changes in hospital protocols for patients requiring surgery in terms of testing requirements, etc. The short and long-term impact of this infection and the pandemic was important in terms of managing these hip fracture patients and prognostication. Our primary aims of this study was to determine if the presence of COVID-19 positivity in hip fracture patients affected their outcomes, and also to determine if there's a difference in hip fracture outcomes during the pandemic era in comparison to the pre-pandemic era. Specific outcomes that we're looking at include time to surgery, length of hospital stay, and mortality data, including 30 days, 6 months, and 1 year. We wanted to outline these baseline characteristics of our patients presenting to the university hospital to see if they are risk or benefit for developing adverse outcomes or improved outcomes, and wanted an updated figure on our overall outcomes using with the parameters as previously mentioned. Our hypothesis was that the time to surgery, length of hospital stay, and mortality were likely to be increased in the pandemic cohort in comparison to the pre-pandemic cohort, or mortality was likely to be decreased in COVID negative patients in comparison to COVID positive hip fracture patients treated at the University Hospital. This was a retrospective analysis done using a cohort from the first wave of the pandemic from April 2020 to December 2021, and a pre-pandemic cohort, which comprised of patients who had hip fracture surgeries between January 2018 to December 2019. We included all patients more than 55 years old with osteoporotic hip fractures admitted to the orthopedic service. We excluded patients who were polytrauma patients, patients with pathological fractures, and readmissions from fractures occurring outside the study period. Data collection, we accessed the registration department to determine all patients who came into accident and emergency with hip fractures. We looked at the physical dockets, electronic medical records, including the radiology and online lab database, operating theater records, and we accessed the Registrar General's department to determine overall mortality. In terms of our data collection, we assessed baseline characteristics, including age, sex, COVID status based on a PCR test, whether they are symptomatic or not, mechanisms of injury, comorbidities of the patients, the ASA scores, tobacco use, and we characterize these fractures, whether or not they were intracapsular or extracapsular, type of treatment that we did for them, and then we assessed the outcomes in terms of the time to surgery, anesthesia use, length of stay, and mortality in terms of 30 days, 6 months, 1 year mortality. We also looked at the causes of death. We abstracted data from data collection forms, did univariate summaries as necessary, bivariate associations, and we compared these cohorts between pre-pandemic and the pandemic using t-test, Wilcox and Ransom test, chi-square test, and Fisher's exact test as appropriate for the data type. Overall, there were 138 patients, 54 were in the pandemic group, 84 patients in the pre-pandemic group. Of these 54 patients, 7 were COVID positive hip fracture patients, 44 were COVID negative, 3 were unknown. 43 of these patients had surgery, and we compared these to the 84 patients who had surgery pre-pandemic. In terms of our baseline characteristics in the pandemic group, in keeping with general worldwide studies, the age was between 80 to 82, 81.5 median, between 59 to 101 years, predominantly females. Only 13% of patients were COVID positive, but this was in keeping with the positivity rate assessed for that period of time. In terms of most common method of ambulatory status, most patients pre-operatively were community ambulant without assistance. Well, that represented 44% of patients, and 80% of patients were treated surgically. There was 54% intracapsular fractures, and the rest were extracapsular. With regards to intracapsular fractures, the most common method of treatment was hemiarthroplasty and intertrochanteric, which were the bulk of extracapsular. The most common method of treatment was DHS, and of note, these are the more easily affordable implants. So in terms of the pandemic outcomes, we noted that the time to surgery was 13 days, median, and the length of stay had a median of 16 days. Mortality at 30 days was 15%, 6 months, 24%, and at 1 year was 33%. Of note, 1/3 of patients who died died as complications of COVID-19, whether or not they had previously got COVID-19 preoperatively or not. When we looked specifically at COVID-19 status and mortality, though there was an increased percentage of patients who died with COVID-19, this was not found to be statistically significant, although approaching statistical significance at 6 months. When we looked at treatment versus mortality, non-operative patients had more than double the mortality of our patients who were treated operatively, with 67% of patients dying at 1 year if they never had surgery, and 28% patients dying at 1 year when they had surgery. When we compared our pre-pandemic versus pandemic groups, of note, there was no statistical significance difference in terms of the age, the sex, comorbidities, and we looked at specific comorbidities, including hypertension, diabetes, stroke, dementia. There's a slightly increased ASA score in the pandemic versus the pre-pandemic group. There was no difference in terms of anesthesia use, and in terms of the length of stay was significantly increased in the pandemic, 16 versus 12 days, and the time to surgery was significantly increased, 13 versus 7 days. The mortality, however, short-term mortality was increased in the pandemic group, 7% versus 0% in pre-pandemic, and at 1 year, it was not statistically significant, 27% versus 28%. So in conclusion, our surgical intervention reduced mortality by more than half in the hip fracture patient population. There is no statistically significant difference in COVID positive versus COVID negative hip fracture patients, but this could be as a result of the small number of COVID positive hip fracture patients in this study. And there's, surprisingly, though there's an increase in 30-day mortality, there is no difference in terms of 1-year mortality when we compared pre-pandemic versus pandemic hip fracture patients. Of note, some limitations included missing records. There's no comparison between the non-surgical patients, which could have been affected more by the various the situations. And there was a variation in terms of COVID testing protocols and requirements during the pandemic period, and we didn't report any specific variant. Of note, our time to surgery is overall too long. So we recommend reducing our time to surgery, creating a fast track hospital protocol, getting patients operated on within 48 hours, which has been shown to significantly reduce mortality in these patients. We need to stop the necessary implants, as these implants tend to be the more affordable ones that we're using most commonly, and creating multidisciplinary teams to see these patients as quickly as possible, considering the use of antiviral treatments in those COVID positive patients to reduce their complications, and implementation of an audit to regularly review our outcomes and assess the success of our interventions. Acknowledging these people who played a part in the study, these are my references.
Thanks, Doc. So judges, take it away.
Sure. So in essence, did you do a post-hoc power comparison to find out why is it that to basically just assess your numbers?
Sorry, I didn't hear.
Did you do a post-hoc power comparison to assess your numbers? Because you only had 7, as you quite rightly pointed out, in your COVID positive group. But why did you operate on them in the first place?
Why did we operate?
Yeah, on those 7.
Oh, not all of those patients were operated on.
Mm-hmm.
Some were operated on and not operated on.
So I think he said 4 was operated on?
Right, so why were the ones who were operated on or not operated on operated on? The ones who were operated on because we know that increases their mobility and decreases their morbidity and mortality over time, whether or not they have COVID.
Right, so why you didn't operate on those other 3?
Those were probably too sick to be operated on.
Okay, so there are other confounders then could have affected.
Yeah, that could be a confounding factor. Another confounding factor is if the patient refused surgery.
Okay, all right.
Thanks, Doc. So next we have Dr. Ozumba, who is going to tell us about physicians' comfort level in caring for the pediatric patient in emergency departments.
Good afternoon. My name is Linda Ozumba. I'm a 4th-year emergency medicine resident. My academic supervisor is Dr. Shubhra Dasgupta. And I'll be presenting today on our research project entitled Physician's Comfort Level in Caring for the Pediatric Patient in Jamaican Emergency Departments. The pediatric patient represents a unique subset of patients in the emergency department. These patients usually present to non-pediatric emergency departments across the country because presently only one pediatric hospital exists in Jamaica, and that would be Bustamante Hospital for Children. Gangahara et al. In 2021 found that general emergency department providers reported a lower comfort level in caring for critically ill children. They had a confidence score of 44.8, and when they compared it to pediatric emergency providers, they found that there was a statistical significance. Gore et al. In 2018 found that emergency providers cited low frequency of clinical scenarios and training as the issues related to caring for critically ill children. No local or regional study exists that looks at physicians' comfort level in caring for pediatric patients in the emergency department, and that forms the basis of this study. The aim of the study was to evaluate physicians' comfort level in caring for the pediatric patients in the emergency departments of University Hospital of the West Indies, Bustamante Hospital for Children, and Spanish Town Hospital between 1st July 2024 and 30th November 2024. One of the objectives was to determine if physicians who work in specialized pediatric emergency departments are more comfortable than physicians who work in a general ED. The other objective was to compare comfort levels of specialized pediatric emergency physicians versus general ED physicians in various procedures, such as intravenous access, intraosseous access, suprapubic aspiration, chest tube insertion, as well as endotracheal tube insertion. We also wanted to look at procedure sedation, fluid management, as well as trauma resuscitation in the pediatric patient. This was a cross-sectional study of emergency physicians in the hospitals previously mentioned between 1st July 2024 to 30th November 2024. So there was no existing questionnaire to carry out the aims and objectives of this study. So a new questionnaire was generated and a pre-testing was done at an institution that was not involved in the study. Approval was gained from the various ethics committees. Permission was gained from each of the emergency departments that was involved in the study. Each of the emergency physicians who were eligible for the study was sensitized about it. Participation was voluntary. Consent form was signed prior to participation, and the questionnaire was distributed and collected by the researcher. The inclusion criteria comprise physicians who work part-time or full-time at UHWI, STH, and BHC emergency department. Also, physicians must have completed internship and SHO year within the hospital system. The exclusion criteria comprise of physicians who did not complete internship or SHO year, also physicians who do not work in the emergency department, as well as physicians who only worked in the pediatric casualty section of the emergency department. And this criteria is placed because we have a pediatric casualty at UHWI. However, those physicians only see pediatric medicine cases. And if a patient comes in extremis or requires immediate intervention, that patient would have to be first seen by the emergency physician and then referred to the pediatric team. So the sample size calculated for BHC was 20, and for UHWI and STH was 38. The data we collected was analyzed using SPSS 29, and an average comfort score for each procedure for UHWI and STH was compared to that of BHC, and an overall comfort level was generated for UHWI and STH and then compared to that of BHC. So this is a pie chart showing the distribution of the study participants. So in blue, 21 physicians from Bustamante Hospital for Children participated in the study, 27 in green from UHWI, and 20 from Spanish Town Hospital. So this is a bar graph showing a comparison of work experience after SHO year. So when we compared the physicians who worked in general ED compared to BHC, we found that the physicians in general ED had less work experience after SHO year compared to physicians at BHC. So for example, 70.37% of the physicians at UHWI had 1 to 5 years working experience after SHO year. 50% of the physicians at STH had work experience of 1 to 5 years, while 10% of the physicians at STH had less than 1 year working experience, compared to 52.8% of the physicians at BHC having 6 to 10 years work experience, and 14.29% of those physicians also having greater than 10 years work experience. We also wanted to look at postgraduate education, and we found that 92.65% of the physicians involved in the study had not completed a postgraduate degree, although 32.35% were currently enrolled in a postgraduate program, mostly emergency medicine, the DM, and the diploma program. So this is a bar graph showing the comparison between the mean comfort level for BHC versus UHWI. And we found that the comfort level for BHC was significant compared to UHWI. And the mean comfort level for BHC was 3.53 with a 95% confidence interval of 3.273 to 3.794. And the mean comfort level for STH and UHWI was 2.88 with a 95% confidence interval of 2.88 with a 95% confidence interval of 2.716 to 3.050. And when these two values were compared, there was a statistical difference. This is a table showing a comparison of the mean comfort level for the procedures and management that were looked at. So in terms of intravenous access, intraosseous access, suprapubic aspiration, endotracheal tube insertion, fluid management, and trauma resuscitation, we found that physicians at BHC had a mean comfort level that was higher than UHWI and STH, and it was also statistically significant. However, when it came to chest tube insertion, there's no statistical difference among the groups. In terms of procedural sedation is not done in the emergency department of BHC, and we found this out when we were conducting the study. So we were unable to accurately compare the comfort level for this procedure. For limitations, we had several limitations when it came to this study. For example, recall bias, self-report data bias, and also variability in training and experience. And as previously mentioned, the physicians at STH and UHWI had less working experience when compared to physicians at BHC, and this may have contributed to the results of the study. Also, there were institutional differences. For example, procedure sedation is not done at Bustamante Hospital for Children in the emergency departments, so that wouldn't have been able to accurately compare the comfort level for that procedure. Additionally, this is a cross-sectional design, so we would not have been able to track the changes in the comfort level over time and how it changes with experience, exposure, and as time goes by. So our recommendations after carrying out this study include enhanced pediatric training opportunities. And what does that entail? Institutional simulation-based training in regards to pediatric emergencies and also procedures. Magage et al. Did a meta-analysis that looked at 14 studies. And the question that they wanted to answer was, what is the effectiveness of simulation-based medical education? And they found that that was extremely effective. Also instituting workshops on continuing education, and also having rotations at a pediatric emergency department. And it doesn't just have to be local, it can be regional and also international. Also standardized protocols as it relates to the pediatric patient across emergency departments in Jamaica. And after these have been instituted, monitor and evaluate the progress of the physicians. So in summary, physicians who work in pediatric emergency departments are more comfortable in caring for pediatric patients than physicians who work in general emergency departments. And thank you.
All right, so I have a few things I just want to run it through. Let's see if we can make them quick.
Sure.
So the first one is, did you adjust in your, so in essence, you're looking at the differences between the comfort level score as a proxy for comfort level between 3 groups of physicians.
Yeah.
Did you adjust for experience, and did you adjust for whether or not they're in a postgrad training or a postgrad training degree?
No adjustments were made for that. And that's something that could have been done, but no adjustments were made for that.
And if you were to adjust, how would you have done that?
That I'm not exactly sure. I guess we could do like a regression analysis or something like that to do that.
Right, you're correct. Let's moving along to the second question. What's the rationale for combining UWI and Spanish Town? Because I think in your original hypothesis, you were postulating or suggesting that there may have been a difference, but in your data, you're presenting them as combined. So what's the rationale for doing that?
So the rationale for combining is based on the aim and objectives. We want to look at general EDs. So we didn't just want to look at UHWI. As we know, UHWI is a teaching center, but it was also to look at other EDs that are not, I want to say under the university, but we wanted to look at other EDs so that the information that we generated could be more generalizable, and that could be used to facilitate protocols or education or stuff like that. So that's why we combine both of them and not just say UHWI.
Okay, that didn't come out in terms of your objectives or specific aim. The last question I want to do, is really an observation, not a question.
Okay.
So again, your sample size slide is uninformative.
Okay.
The second part about it is that you also had a bar chart in which you said that you had a standard error 95% confidence interval. roughly, we don't know what any of those bars represent because it could represent either of those two things. So probably suggest that there's some mislabeling on that chart.
Okay.
Okay, thanks for your presentation. I think Prof. Reed asked about the sample size. I was asking what was the rationale?
For the sample size?
Right, but
Okay. So the way the sample size was generated, we got the number of physicians who were eligible for the study based on the inclusion and exclusion criteria from each of the emergency departments. And then we know that most are not going to participate. The aim was to get all of them to participate. But then we did a sample size calculation in terms of using a 95% confidence interval and a 10% margin of error. So that's how we calculated it.
okay, well, as you indicated, there's nothing on the slide. But if I remember the slide, you said you had 20 plus 38, which would have been 58 persons, but your total was 69. Any reason why you oversampled?
So honestly, wasn't keeping track of the number of physicians who were answering the forms. So at one point I realized, okay, collected enough questionnaires and that's really what happened. But a part of the study really and truly wanted to get most of the physicians. So that was another reason that we oversampled as well.
Okay. My final question, was there a problem where you wanted to find out what was the comfort level of regular versus pediatric?
So it mostly has to do observational. There's an apprehension that I've noticed when it comes to physicians, and they realize it's a child that's next to be seen. And because of that observation, I wanted to test, is this really true? Is this something that really exists? And if it does exist, what can be done to change it? So that's where it came from.
All right, thanks for your presentation. My main questions have been asked in terms of the grouping. I didn't understand why that was done. But what I'd like to ask you, because you gave a number of recommendations, which I don't really think they fit with, your results. So for me, what I'd like you to tell me, Dr. Dasgupta is going to want somebody else to take up this study. What's the best advice you could give to that next DM student?
One of the advice I would give them is do a longer time period in terms of tracking the physicians. So one way would be, okay, let's do simulated procedures, let's do simulated emergencies, do a pre-procedural survey and a post-procedural survey, because they have done that in the US, where they have one study they did for simulated pediatric emergencies, and they did a pre-survey and a post-survey, and they did that over several months, and they tracked the change in terms of how comfortable the physicians were. So that's something that can be done. Also in terms of seeing if there's any correlation between physicians' postgraduate training level and also how they deal with the pediatric patient. That's something that can be looked at as well in further studies.
Thanks, Doc. Next up, we have Dr. Pringle, who is going to be talking to us about intensive care capacity in Jamaica, and she did a national study.
Good afternoon, everyone. I am Dr. Amanda Pringle. I'm from the Department of Anesthesia and Intensive Care. My advisor is Dr. Kelvin Metalore, and we decided to embark on this study entitled Intensive Care Capacity in Jamaica, a National Cross-Sectional Study. As we know, ICUs provide life-saving support for patients in severe medical crises, and a shortage of ICU beds are directly shown to impact morbidity and mortality. And at the time of us embarking on this study, there was no published data on ICU bed capacity in Jamaica, which makes us unable to adequately plan for surge capacity, which was clearly evident during the COVID-19 pandemic. So the objectives were to determine the number of physical ICU spaces and functional ICU beds per 100,000 population in Jamaica. We also aim to redefine the institutions identified by the study into ICU levels 1 to 3, And we also decided to describe the characteristics of these ICUs, including staffing, monitoring, specialized equipment available, and critical care isolation facilities during the time period of October to November 2024. So ethical approval was sought and approved by the necessary bodies, and our study was a quantitative cross-sectional multi-center audit of ICU capacity, as I said, between the months of October to November 2024. We included public hospitals that stated that they had either an ICU or HDU, and we excluded pediatric ICUs, the emergency department, and also the post-anesthetic care units. Data was mainly collected via self-administered forms. So we need to clarify some definitions first. So we use the World Federation of Societies of Intensive and Critical Care Medicine Task Force definition for an ICU that states that it is a physical location within a hospital that is dedicated to and has provisions for supporting critically ill patients. It provides 24 hours of specialized care. The ICU classification that we use were between levels 1 to 3, with 3 being the most specialized and 1 being the most basic. And also the HU definition was one that it is a step up or step down unit between the ward and the intensive care unit. It's also important to note that ICU bed capacity is defined as a number of funded and fully staffed ICU beds at a specified point in time. So we have to look at Jamaica's healthcare system firstly. It was decentralized into 4 regional health authorities in 1997 as the SERA, or Southeast Regional Health Authority, Northeast Regional Health Authority, Southern Regional and Western Regional Health Authorities. And they are also further subdivided into types A to C, where A is the most specialized hospital and type C is the most numerous yet the least equipped. We approached the Ministry of Health and Wellness. They were able to provide this data. This is what they had on record as of November 2024 as our ICU capacity. It is also important to note that though the University Hospital of the West Indies falls in the geographical location of the Southeast region, it actually is an independent entity. So we're getting into what we found. And as we see here at the top that's highlighted, the University Hospital of the West Indies has 18 beds. But if we subtract this from the equation, because it actually does not form a part of SERA, we are left with approximately 17 or 18 beds for the entire SERA. Another important thing that I wanted to highlight was that the Northeast region had 2 high dependency units. Well, 2 high dependency unit spaces, and this is a region that serves over 500,000 persons. So ICU beds per 100,000 per region, we found to be 2.7 beds in Southeast Regional Health Authority, 0.8 beds, and SERA and, well, Southern Regional and Northeast Regional Health Authority had 0.5 beds per 100,000 population. Just to bring this home, that works out to approximately 1 bed per 200,000 persons. That's pretty bad. Okay. So overall, we found that the ICU capacity in Jamaica is 1.62 beds per 100,000 population in Jamaica. To compare locally, the University of Martinique has 70 beds for a population of 300,000 persons. So that's about 30 ICU beds per 100,000. So you can see the disparity here. Globally, in countries such as Germany, we see even numbers of 33 ICU bed spaces per 100,000. So you can see that our numbers are quite dismal. We decided to take each organ system, a form of monitoring. So we looked at ventilators, ECG machines, advanced neuromonitoring capabilities, also renal replacement therapy. There's a lot of red on this chart. You can see that there are deficiencies. The Spanish Town Hospital, for example, had 0 functional ventilators at that point in time. As you can see, the University Hospital of West Indies is the most equipped. In terms of staff availability, we saw similar numbers. The medical staff was most equipped at the University Hospital of the West Indies, least equipped at Savannah Lamar and also Princess Margaret Hospitals. And also the nursing staff, I want to highlight that it was as low as or as bad as 1 to 3 or 1 nurse to 3 patients. Global standards state that this should be a 1-to-1 ratio. So this is also concerning. With regards to facility and safety standards, we noticed also that 20% of the hospitals had no alternate power supply. This number should be 0% because if we do have power outages, what happens in those situations? Also, 45% of hospitals lacked easy access to the operating theater. In terms of infection control, there were only 2 functional negative pressure rooms that were available in the entire of Jamaica. And these were located at the University Hospital of the West Indies as well. And we also saw the repercussions of this shortage in the COVID-19 pandemic. So we decided to reclassify these ICUs based off of the same body, the World Federation of Critical Care Medicine, and we found that only the University Hospital of the West Indies would actually fall in a level 3 ICU. There's quite a few that would fall in a level 2 category and 3 that fall in a level 1 category. We did have limitations. Data collection was challenging. There is no electronic database that exists, so this was mainly self-reported data. It was a limited time frame between October and November 2024, so it's more of a static snapshot of what exists in the country. And there was also a lack of standardized definitions. The Ministry of Health and Wellness have no clear guidelines for ICU or HDU classification, which made it a little bit difficult. We recommend that additional funding be focused on especially the Northeast and Southern regions where there is a combined 5 beds for 500,000 persons. We would also recommend that we increase medical and nursing staff so that it looks more similar to international standards. We need to install backup power and emergency lighting in all departments. And also implementing an electronic inventory system would also help greatly in maintenance tracking. Future research obviously is needed. This is the first time that we've ever attempted to do a study of this nature. And so bringing us to our conclusions, we have a severe shortage at 1.62 ICU beds per 100,000 persons. There are severe regional disparities. There is no systematic maintenance for ICU equipment, and there is definitely a call for future research and ongoing studies to understand and to correct some of these disparities. And that's the end of my presentation.
Thanks, Doc. So I'm going to put the judges on hold. I got a little bit of a whipping that the audience doesn't get to ask questions, but I haven't seen any hands. Does anybody on the floor have any questions? Okay, Dr. Krigi.
High dependency unit. Okay. That is what Mandible says there. Yeah, it's a high dependency unit, yes. Okay. So
Oh, no, I was just wondering about Mandible. You said they have a HDU, right?
Yes.
In the beginning, when you were introducing it, did you say HDUs were included in the study? I just didn't remember. I just don't remember.
They were. It was part of the inclusion criteria.
Right. Okay, that's fine.
Okay.
Anybody else?
Very interesting presentation, and I like the use of your graphics. You made a good effort with, bringing out the graphics, which was really good. So I'm going to pretend that I'm the Minister of Health who has no idea about medicine, right? You're trying to convince me that the number of ICU beds around the island are just adequate. What data do you have to show that there is an actual demand? I mean, I just thought that would have probably been useful. I mean, I'm not going to put a bed if there's nobody coming in needing an ICU bed.
That's actually an interesting question. There is ongoing research. Someone else in my year actually is capturing the demand of ICU. So that will be something to come in the future. That's it. Okay.
Seems as if we're out of questions. So thanks, Doc. Very good presentation. So next we have Dr. Samuels, who's going to take us a bit, tell us a bit about time to decompress patients with malignant lesions in their spinal cord. Come down.
Hi, good day, everyone. Thanks for having me today. So I said before, I'm Tramar. My supervisor is Dr. P. Charles for this research. Oh, sorry. All right. So my research is, let's evaluate the impact of time to decompression on the outcomes of malignant spinal cord compression at the University Hospital of the West Indies. Now, just to create the framework, malignant spinal cord compression is compression of the spinal cord and or the cauda equina due to malignant disease. Now, the spine is actually the most frequent site of osseous metastasis, with metastatic spinal cord compression occurring in 5 to 10% of all cancer patients, and a staggering 40% of all cancer patients with known bone metastasis. Now, for 10 to 20% of patients diagnosed with cancer, metastatic spinal cord compression is actually the initial manifestation of malignancy. Now, clinically significant symptomatic spinal cord metastases are actually predominantly localized in the thoracic spine, followed by the lumbar, and then the cervical. Now, there's actually a lack of local data, but in the US, there's more than 20,000 new cases of metastatic spinal cord compression, which are actually diagnosed annually. Now, of this disease burden, lung, breast, and prostate cancer are collectively accounting for probably about 60% of cases, while 7% of patients have an unidentified primary tumor site. Now, given that most patients with metastatic spinal cord compression die within the first year of diagnosis, and associated morbidities such as progressive pain, sensory loss, spinal deformity, as well as loss of sphincter control, metastatic spinal cord compression remains a critical medical issue, which I believe warrants further study. Now, at the University Hospital of the West Indies, it is noted that there's no audit directed to patients with metastatic spinal cord compression. Now, this study was conceived with the hopeful aim of contributing to improving the care of these patients who present with this pathology. Now, in terms of my methodology, I had an inclusion criteria. I started my study in 2020 of June, and I ran it all the way to July in 2023, covering 4 years. Patient information, operation notes, along with clinical details, including intraoperative and post-operative complications, were collected retrospectively from patients' notes and online databases. Now, the inclusion criteria dictated that these patients had to be 18 years of age with a clinical and radiological diagnosis of MSCC, irrespective of the status of the primary tumor or as well as who underwent spinal surgery. My exclusion criteria included patients who would be less than 18, not desirous of surgery, patients who were not surgical candidates, and patients who had prior radiation to the craniospinal axis and therefore having a recurrence rather than a primary disease. Now, in terms of my data collection, I did look at the age, the gender, relevant comorbidities, the origin of the primary, if it is known, and the site of the spinal column that is involved, and confirmed by radiological means. Of note, the motor score / the ASHA grade was the best value that was found after examination of these patients from a 3-month period from the surgery itself. Now, just to move on to some of the results, unfortunately, we only had a small sample size of 22, and with our elimination or exclusion criteria, we had to take out 1 patient. Now, of the 21, we realized that a large proportion were males and a smaller proportion were actually females, being 14 and 7 respectively. In terms of the age distribution, we realized that our population here who presented with MSCC were actually in the older population, being definitely greater than 60. In terms of the distribution of the symptoms that these patients presented with, by far, all patients presented with the most common symptom of being paresis, followed by paresis and back pain. Now, in terms of the distribution of where were these pathologies located, now this diagram essentially shows that just as how the data has showed, as well as the literature review, we also too see that most of our patients present with thoracic pathologies, just as international studies are shown. Then in terms of what is the distribution of these primaries, a lot of the samples or biopsies taken actually come back as being negative, followed by being from the prostate, followed by bone marrow, followed by breast. Of course, the most common histology then would have to be adenocarcinoma, followed by a negative biopsy. Now, in terms of our results, what were some of the procedures that were offered to these patients? And we found that by far a single level decompression was the most frequent decompression that was offered to these patients. Now, in terms of distribution of the outcomes, we found that by far a large proportion of our patients actually had a 5 out of 5 power on this within the 3-month period of evaluation post their decompression. This correlated with the Asia score of E, which is 3 months post their decompression. Now, what is actually our time or frequency of decompression here? Now, we found that unfortunately we decompress our patients greater than 72 hours from presentation. So internationally, it is recommended to be less than 48. But here, due to multiple factors, we unfortunately decompress greater than 72 hours. Now, in terms of what are the Asia scores before and after decompression? So surprisingly, even though we are decompressing greater than 72 hours, we're not really having a worsening of our decompression from their presentation to after this decompression, where we've seen that 13 of the 16 patients who were decompressed greater than 17 hours actually did not have a deterioration nor improvement, but remained rather unchanged post their decompression. So in terms of the analysis, so by categorizing and doing a play of the data, using the time to operating table, we categorize it into groups such as short, medium, and long, and then using ANOVA to compare the mean motor scores or Asia scores across this time. It actually yielded an ANOVA test with a p-value of 0.47, which unfortunately was not statistically significant. Therefore, there's not really any evidence to suggest that there's a statistically significant relationship that existed between time to decompression and the outcome based on my model on this model of analysis. We then went on to use the Pearson correlation, which showed that the time to decompression and when compared to the motor score had a p-value of 0.64, and when compared to the Asia score had a p-value of 0.325, which are also not significant. So the manual EU test was conducted due to a non-normality of the time to decompression data. This, however, also further supported the conclusion of no significant relationship occurring between the two. That being said, we were still able to conclude that 76% of the patients would be offered treatment 72 hours post-presentation, albeit of this number, 81% would not have any further deterioration in their neurology. Now, there are some obvious limitations with this study. Of course, we had a very small sample size. The confounder was the use of dexamethasone, which was used in over 81% of the patients, which is before surgery. Now, post-decompression, a lot of patients will be referred to radiotherapy, many of which there was actually no record to prove that they obtained, which would have impacted their overall outcome. So now, in the literature used the timing from onset of symptoms. Unfortunately, in our population, patients present 2 weeks, 1 month, 4 months after feeling initial paresis. So that would have skewed the study too much, and we had to use time to presentation. But by right, it should have been time of symptomatology to surgery. So while the motor score is not the most accurate representation of overall limb function, the ASIA score alone simply does not allow the representation of an incremental motor improvement, unfortunately. And these are some of my references.
Thanks, Doc. Any questions?
Just a few.
One sec, Prof.
Yes, sir. Yes, sir. Oh. So in terms of the choosing 72 itself. So based on when I reviewed other studies, so they had the same means of being less than 24, 24 to 48, 48 to 72, and greater than 72. So of the patients that had the 72, there was actually no deterioration, and 3 actually improved despite being over 72. Now the others, such as even the patients who were less than 24, actually did have deterioration, even being done less than 24 hours from presentation. Was what I found.
So you might benefit from splitting up that 16 into narrower bins. Additionally, you might benefit from actually doing a time analysis. So looking at time as a specific variable.
Okay, thank you, sir.
Thanks for that question. I think I don't see any more hands. The judges, of course, have some burning questions. You ready, Doc?
No, it's not burning questions. I'm just confused. So on one hand, you have your time to surgery as an outcome, and then as another approach, you're treating your time to surgery as a predictive variable. And I'm not sure if I understand what it is that you really want to do.
So sorry for the confusion, but the aim was to use time to surgery as the predictive variable, and the outcomes being measured would be the ASIA score and the motor scores. Sorry about that.
All right, so that's fine. And then post-op, when you collected your data, you found that you had 5 in one group and 16 in another group, right? Where 5 was less than 72 hours and 16 was 72 and above.
Yes, sir.
All right, great. And so your outcome now I'm gonna look a bit better. So your outcomes would have been those funny ASIA score things and all of that sort of things.
Yes, sir.
All right. Now, you then presented a whole slew of analysis, right? You did Pearson's, you did this, you did that, you did all kind of funny stuff, all right? But the issue for me is that it sounds like you are trying to play darts. You are throwing something on a dartboard and hoping that something sticks. So traditionally, how we approach these sort of issues is that we define what our outcomes are, we define what our predictors are, and then we choose the most appropriate analysis to answer the question. And I think part of the problem that you have is that you, in terms of stating your question, one, your question wasn't clear. I don't know what evaluate means. That's I probably have to look in the English dictionary to find what that means. But typically what we would do, would say exactly what we're looking for so that we can then do an appropriate analysis. So I found that your presentation was really a description of fishing. How do you go about fishing?
Thank you, sir.
Okay, just wanted to find out, what are some of the other factors that are related to time to decompression?
All right. So from a literature standpoint, it is recommended that one, this requires proper clinical evaluation, proper radiological workup, proper assessment of the patient to ensure that this patient is physiologically fit for surgery, as well as time to have proper consultation with multiple discipline, having a multiple disciplinary approach, which I said the sweet spot is somewhere less than 48 hours before. Now, in our population, it seems as if it was multifactorial as well. So one, the patients did present late. So when a patient has a significantly decreased motor power, we sometimes seem to be trying dexamethasone to see if surgery would benefit them at all, because they actually come in way past the recommended period of decompression, 2 weeks, 3 weeks, 4 weeks. So there can sometimes be a trial of dexamethasone, and if the patient improves, then I realize it would tend to want to shuffle them towards the surgical arm as well.
Okay, thanks, Dr. Samuel. So there are a couple more questions from the floor, but I'm gonna allow Dr. Vassell to present. He has been here for the duration and he is dying to share something with you. So he's one of our radiology residents and he's gonna speak about chronic kidney disease. Actually, yesterday was World Kidney Day. I'm not sure if you all knew that. Anyway, Doc.
And month. Sorry? Diane? Well, partly. So I'm Suwain Vassell, and I'm a third-year resident in the Department of Radiology, and I'll be presenting an analysis of the prevalence of pulmonary embolism in patients with chronic kidney disease and ESRD. So this is my outline. So pulmonary embolism is the third leading cause of vascular mortality globally, and with a higher incidence in persons with CKD and ESRD, due to their hypercoagulable state, endothelial damage, and dialysis access. We believe that with a lack of data locally, we would have benefit from this study, all right? Also, Singh et al. In 2021 showed from a national inpatient study that inpatient mortality and the duration of stay is also higher in these patients. So this is a theoretical framework as per Virchow's triad, why these patients are at higher risk. So the aim of this study was to analyze the prevalence of PE in the patients with CKD and ESRD at the University Hospital of the West Indies. And the objectives were to assess if there are gender and age association between patients with CKD and ESRD with PE, and also to compare the length of stay and 30-day mortality in patients with chronic kidney disease and ESRD versus patients who had normal renal function. So the methods that we went about to collect this data was a retrospective cross-sectional study that analyzed data from all the CTPAs that were done at the University Hospital of the West Indies between June 1, 2023 and May 31st, 2024. And these were the inclusion criteria being age 20 to 90, a confirmed CTPA, and the diagnosis of CKD and ESRD. And these data were gathered from the CTPA reports that are available on the risk system. When this demographics is collected, it then entered into the LIS, where these EGFR are then gathered, and then this EGFR, if it's greater than 3 months, all right, given the diagnosis of CKD and ESRD, was then cross-referenced with the information on HIMSS, and of note, there were 1,368 patients that did a CTPA. When the inclusion and exclusion criteria were applied, we got 1,247 participants. Of note, we wanted to compare between persons' duration of stay and the mortality rate. We needed a control group. This control group was selected from the minimum, 30% of the minimum required to be sampled for this study to be validated. And then we got a control group of 38 random participants. And this was done by calculating having all patients with a normal renal function with PE, and then use a random number generator to get 38 random patients. So the data was analyzed by the software and statistical tests. So the results, out of the 1,247 patients, 1,106 patients had a normal kidney function, 101 had CKD, and 40 patients had ESRD. So this further elaborates the demographics of these patients and then break it down into various age categories and to state if these patients went on to have a positive finding for PE. So it was of note that the gender preference was that 65% of patients were female, and then 35% were male, and the average median age was 65 years old, with females being an average of 57 and males being an average of 64 years old. So when we got the patients that were diagnosed with CKD, we then further analyzed if these patients were positive for PE. And then the results were astronomical because patients with ESRD and CKD had a prevalence rate of 31% versus the overall prevalence being 22%. And then persons with CKD and ESRD having an odds ratio of greater than 2 times of that of normal renal function. So we then went further to see what are these predictors of a PE, if it's related to age, sex, or renal function. It was noted that persons between the age of 60 and 90 had an increased odds ratio of greater than 6 compared to persons that were younger, and this was statistically significant. However, there was no sex difference in a predictor of PE, and an abnormal kidney function had an odds ratio of 1.7 of developing pulmonary embolism. So we then further went on to analyze the mortality rate and length of stay by comparing persons with CKD and ESRD to persons who have normal renal function. And the 30-day mortality rate for persons with CKD was 27% versus persons with normal kidney function being 16%. And the median length of stay for persons with CKD was 7.5 days compared to persons with normal at 5.5 days, so spending an additional 2 days in hospital. So of note, males were also noted to have an odds ratio of 1.8 times in hospital stay compared to their female counterparts. So as I said before, there was a 4% increased odds for age versus, and there was no mortality predictor from sex or length of hospital stay. So the key discussion points from this study, based on the characteristics of the study population, was that patients between 60 and 69 years of age was the largest presentation, and persons between 60 and 90 had an increased risk factor. And of note, the prevalence of kidney disease were higher in women, and ESRD was surprisingly higher in males. Based on our study and studies globally, there is no real cause or association as to why this is so, but it does reflect international studies. And CKD patients do have a higher risk of PE prevalence. So therefore, the outcome with an age greater than 60, you're at a critical risk. And then persons with CKD and ESRD have a higher mortality and longer length of stay, and there is no gender disparity of this outcome. So in concluding, the prevalence, mortality rate, and length of hospital stay with pulmonary embolism is higher in patients with abnormal kidney function. So the limitations of this study were that it was a single study, center study, only at the university, and it was a retrospective study, introducing retrospective bias. So based on these, now we were wondering if there could be some CKD, ESRD pathways with collaboration between nephrology and emergency service. We could implement things like screening, things like adding D-dimer or even low anticoagulation to further minimize these risk factors. But with all the studies globally, one of the major recommendations is that it starts at a primary care level as to prevent CKD and ESRD prior, because those are irreversible as to a way going forward. These are my references. Thank you.
Thanks for your patience, Doc. So questions from the floor, questions from the judges, hands up.
Well, I'm completely confused, but
Yes, I'm just as confused as Professor Reed, because your title of your presentation is an analysis of the prevalence of pulmonary embolism in patients with chronic kidney disease. So your denominator would be patients with chronic kidney disease. And in that population of patients with chronic kidney disease, you would look at what proportion of those patients have pulmonary embolism. But you started with a group of patients who were diagnosed with pulmonary embolism. And then of that group, you pulled out those who have chronic kidney disease and those who didn't. And so I'm totally confused, because I don't think you can do a prevalence study like that. Your denominator has to be the patients with chronic kidney disease. So I'm not sure if that's what Professor Reed.
So based on the study, it was all the patients that underwent a CTP, had a CTP at the University Hospital of the West Indies. And then when these demographics were analyzed, that's when we found out that they had CKD and ESRD. And then after we found out if they have CKD or ESRD, we'll find out the prevalence of pulmonary embolism in those patients.
So you have to change the title of your study, because you're not really looking at the prevalence of pulmonary embolism in patients with chronic kidney disease.
you're not.
Okay.
That's it?
Well, if this thing is flawed, it can't gonna work.
Take time with him. All right. Thanks, Doc. So Mrs. Ruth Russell Hutton of the MPS is one of our sponsors, and she has been patiently waiting to make her presentation. And you're going to ask, why is she talking to us? Well, they are feeding us. Don't bite the hand that feeds you. So come, Mrs. Russell, and Sister Booth is reminding that you all have evaluations to fill out for your CMEs. So you can leave them on the table at the end of the proceedings. So, Mrs. Russell.
Thank you kindly. Good afternoon, ladies and gentlemen. It's a pleasure to stand here to talk with you. I'm certain a lot of you probably are saying to yourselves, oh, that's where I know that face from, because you've been seeing me walking the aisles of A&E for a while. My dad was here as your guest, 24 days in A&E. But we're here to share with you on MPS, Medical Protection Society. We are the world's leading non-for-profit mutual organization, which means the moment you join, you become part owner. There's no profit sharing at the end of the year for the CEO or anybody for that matter. Every red cent that comes in goes out to support members. We don't offer insurance because we're not an insurance company. We offer discretionary indemnity, and the word there is discretion. You practice medicine daily. You need discretion, and that's what we are able to provide. Membership provides you with access to expert advice and support, along with the right to request indemnity for complaints or claims arising from professional practice. Last week, the first thing I said in a presentation at a conference, I came up with this big brown envelope. I'm going to share it with you. Working with the laws of average, it means that every single person within the hearing of my voice will, throughout their professional career, receive at least one of these. You might be wondering what I'm referring to. It's called a pre-protocol action letter, which means a patient is suing you for clinical negligence. Are you ready? Are you prepared? Are you in the right space? So our purpose is to protect your career, your reputation, and your financial security. The highest payout that MPS made in its career of over, I think it's 260 years, was made in Hong Kong about 5 years ago to the tune of 250 million pounds. I'll let that sink. Our footprint is across the Commonwealth. We have a local team here in the Caribbean, small. And for those of you that are members, would see emails flash across your desk from Andrew Bromfield. So you may get quite a little view of what Andrew actually looks like. And yours truly as the manager for the region, we have a rep in Trinidad and Tobago. But of course, if I live here, yes, you'll continue to see my beautiful face more often. But how do we support you? There are two main areas. We have claims and non-claims. And you might think, sure, I'm not interested in nothing else apart from the lawsuit. However, the non-claims take much longer and they tend to cost far more money because you're dealing with the regulatory matters. A quick peruse of the room tells me that we have some way up in the chain and some way in the middle and some way at the bottom. Now, here's how you get support for non-claims issues. Patient complaints. You're hauled up in front of your HOD, HR, maybe even to the medical council. Turning up at that session with your beautifully typed report, perfect. But turning up with an attorney beside you to speak on your behalf, to represent you, is a different story. Disciplinary matters, criminal investigations, I like to call it those pesky coroner inquests, medical council investigations. I'm certain you've seen a few on the newspaper or on the 7 o'clock news. Dr. X or Y has been struck from the medical registry or suspended from the medical registry for 6 months, for a year, forever. So we also provide help with unwanted media attention. Should your name land in the Observer, the Gleaner, social media, TikTok, Instagram, Dr. So-and-so did so-and-so, and you're thinking, I went above and beyond for this patient. How could they have done this? I'm going to take up this phone and give them a piece of my mind. We say take up the phone, yes, but save the great matter for yourself. But call MPS if you're in membership, because we have a press room that's open 24/7. Someone will be there to prepare you, to guide you, to coach you. But also to what you may think as the biggie, clinical negligence claims and support, back to the envelope. You have the right to request advice and legal representation. And here in Jamaica, our panel firm is Livingston, Alexander and Associates. So we are here to support you. And when we say support, it means instructions will be sent from the office in England to the legal team here in Jamaica, an attorney assigned to you. You are prepared in advance.
the attorney speaks on your behalf and follows you through the entire process from start to finish. How much do you pay for that? Your annual subscription. Yeah. However, one thing I'd like to state categorically, I spoke about the largest payout that we've ever had. Here in Jamaica, we do have an indemnity limit. And I'm pausing for emphasis. It's only 270 million Jamaican dollars available per claim per year. Because yes, you can be sued more than once in a calendar year for clinical negligence. Whether you want to consider yourselves being unlucky or unfortunate or manna falling from heaven, whatever it is, it does happen. I see them that fall across my desk on a daily basis across the region. So this is how we are able to support you. We are cognizant that you are busy. So checking emails is so difficult some of the times, responding to calls even more challenging. But with COVID, what we've done, you're all working here in the hospital. Some of you may be working part-time private, some of you may be doing sessions. So the product that we have to taper to suit you is really dependent on what you're currently doing. So if you're working 40 hours in the hospital and you're doing sessions outside of that, there is something for you there. I close with my call to action to say, if you're not yet in membership, scan the QR code. Membership with MPS at the moment is free for medical students, for interns and house officers for their 2 years, after which you become a paying member. And I'm gonna tell you, we don't normally disclose figures, but I'll tell you what that figure is. It's a massive figure of just $10,000 plus Jamaican for the year. It's not a big to do because we recognize that at that stage of your professional career, you're at the bottom of the ladder. You're climbing it, but you're not quite there yet. With that, if you have any questions, any queries, don't wait until you see me walking in the halls. Take a picture of this one. There's my email address, my telephone number, and I see your hand because I'm done.
So what is the regular fee? Is it by year?
Okay, so that depends on what you do, where you do it, and how long you do it for.
Right. So the range is from?
That can be as high as almost $1 million, depending on your specialty. We don't need to call those names, to as low as 100-something thousand or 80-something thousand at the bottom of the ladder. It's a wide scope and it's really dependent on your specialty, the level of risk. I mean, you would not want to compare a family practitioner beside a neurosurgeon or let me find another one, a neonatal or a plastic or an orthopod working in the meninges. You have risk and you have higher risk and you have lower risk. That really, no two persons will ever have the same experience. It's dependent on what you're doing.
All right.
The good thing though is if you intend to go across the Commonwealth, your membership is transferable. You can take it with you as well. Not just the Commonwealth, but let's focus here, the Caribbean.
Okay. And then, so there's this thing called health tourism.
Health
tourism, where you have patients who come back to Jamaica and do their checks, etc. And it is thought that if you look at these patients, treat these patients, you'd carry a higher risk. Is there anything like that in the MPS, or is it all the same, or doesn't it matter?
That's an excellent question, and I thank you for asking it. First thing is that you are indemnified for telemedicine.
Right.
That yes, you are categorically covered for telemedicine. Now, health tourism, you need to look into some parameters. And the first thing I would recommend before even talking about MPS is stating, have it written in your fine print that whomever you treat here in Jamaica, if something untoward should happen, they cannot take any legal matter anywhere else in the world except here in Jamaica, because you certainly would not want
to be served one of these for a patient from Florida or anywhere in North America. That's not a pretty thought. So that's the first point. So what we do say, you will have physicians treating patients, but if it is who are coming here for a procedure, some things that you want to take into consideration is, what are you doing? Is there additional follow-up possibilities or in place for when that patient leaves? Should an emergency occur, what happens then? Who manages the patient? If you're able to have the answers for that, you're fine. If you don't have the answers, my suggestion would be to find the answers for it. But if it is a matter of seeing the patient, the tourist on the cruise ship got sick, tourist at the hotel got sick, you went and saw them, you need to talk with the patient afterwards, they're back home or whatever it is, you are indemnified for telemedicine. Most welcome. I see my host to my periphery.
Hi, hello? Can I ask a question?
Aha.
Hi,
Yes, man, Dr. Charles.
how are you?
Good.
I do agree with you that the more surgeries, okay, I'm a surgeon, the more surgeries you do, the more cases you take on, the greater chance you'll get a brown envelope one day. I do agree with you. So I think protection is very important. But after you get that brown envelope, the question is, how much time do I have before I have to report to you?
The quicker, the better. The moment you get that envelope, it's a matter of reaching out to us online or making a phone call. We have a toll-free line set up for members in Jamaica now. That's one of the first things I instituted. So you don't have to worry about a long-distance call to London here. It's a little about your sex, race, orientation, or your trade union, and you're waiting, and you're thinking, look at this long-distance call. It's a direct call, toll-free. You call, they'll tell you what you need to send and by when, and the conversation begins there. No, the quicker you can send it, the better, because the moment you sign that document from the courier, the clock starts to tick on your side. Whether you're aware of it or not, it's a ticking time bomb.
So I'm getting to the point I'm trying to get to is, I had MPS for many years. And I'm saying this for everybody to understand what my experience with MPS. I paid almost $5,000 US per year for about 10 years. At the end of 10 years, while being an MPS member, faithfully paying every year, I got a brown envelope. Somebody who dressed in a porter clothes came to me in the clinic and gave me a brown envelope in my hand. I signed nothing. I didn't even know what was in there. I looked in there a few hours later. When I read it, it was a case of a brain tumor I operated on that I told had a risk of having a stroke. And the person still had a stroke after. And the family was suing me despite me telling them that risk existed. I spoke to, it was a TT wing patient. I spoke to the administration at the time. They said they would handle it. About 6 months passed and I got a notice from the court. So I then called MPS, told them what happened, and they said, Doc, we can't help you. You're on your own. That's my experience at MPS.
So
that was the last day I paid insurance to MPS.
When did you send the notification to them?
To who?
MPS.
I said it's about.
Sorry, I missed that part.
Right, sorry. After getting that envelope, talking to Tony to its wing and seeing how best this could be resolved. And they told me it would have been resolved. About 6 months later, a notice came from the court. And once I got that notice, I called MPS the same day. And I said, the fact you had that gotten us, were served a few weeks to months before, and you didn't call us, despite paying all this money, all these years, you're on your own. That's the last day I paid MPS $1. That's been my experience with MPS.
I can understand your challenge.
And I think I spoke to you about it too.
Quite so. Remember, I was your next door neighbor at the time.
I spoke to you.
I can understand the situation and your challenge. However, if you fail to notify us within an appropriate time,
what is the appropriate, as I'm asking
the
you?
moment you receive the notification, it doesn't matter if you're going to be speaking with the other parties involved.
So
there's no set timeline, but as quickly as
I was told then that there's some small fine writing somewhere, which I've never seen, that says if a certain time passed and I didn't tell you, then I'm on my own. So I had to get my own lawyer, so everybody can know. Fortunately, the case was dropped. Spent almost $5 million with my own lawyer to get it dropped. It's dropped, but I no longer pay MPS $1.
The thing is, you know, you have to remember that a lawsuit does not happen. The wheels don't turn overnight. It's a very lengthy internal process before it even lands in the court. And when I say lengthy, I'm talking about years. It doesn't happen overnight. You have to take note of that. And that defendant is busy doing everything to ensure that they get, at that stage, they're not interested in an apology.
I think
they want the payout. So what I will say as a compromise to you, Dr. Charles, and to everybody here, I will find out because there is a time frame within which I'll let you know what it is categorically. But my advice would be the sooner the better. And 6 months is not going to be soon. Treat it as an emergency. Your professional career, because what you don't want, and this is the harsh truth, you don't want this to escape once it hits the public space. If you can't recognize them, I see them now and I nod and smile. They're in A&E. We call them the ambulance chasers. They're there. You go to TTW, you go to UWI, you go to UWI, they're there. Just waiting to find the one irate patient, caregiver, or family member to begin the conversation. The society is becoming far more litigious than we can have ever expected or imagined. So it's not a matter, as I said, if we're working with the law of averages, it's not a matter of if, but simply when.
Again, for surgeons and inventors, people who do radiology, when you consent a patient and neurosurgery, we make sure we tell patients everything and document everything on a paper. Very important to document what the risk involved. Even if the patient signs to that, and one of those things occur, understand that patient can still sue you.
Of course.
Yeah, we know. Yeah, we know.
And it's their right.
Also, my learning to them is that if you actually ever get a brown paper from any strange person, whatever it is, if you have MPS, let them know the same day.
Yes.
Don't trust that they're there for you in their future.
I'm going to
Don't do that.
I want to say.
Okay? Don't do that. All right?
Thanks for that interesting presentation, interesting sharing of experience. And there's only one thing I have to say, Mrs. Russell-Hutton. If we have some sort of a contract, there needs to be something in writing to tell us when is the timeline, how many hours. You see, we have been making sure that the residents, the presenters, they're doing this and that. Everything needs to be in apple pie order. Oh, you didn't define that. So you need to have it stated in plain English that if you contact us greater than 42 hours, 48, 72, whatever, after you have been served, you're on your own. It needs to be in writing. It's too much. No, but I don't even know where to look for it.
Find it. So our compromise, while we're getting ready to wrap up, is I will find it and I will share it with you, Dr. Soares. Well, I'm saying it's immediately, but not more than 6 months. With that, I say thank you
All
for your
right.
time.
Okay, thank you so much. And as I said, they have provided some refreshments. So now we're gonna hear from the judges. And we do have prizes which will be shared next week. You can collect from Miss Bennett. There are physical prizes, but they're gonna tell you the order of appearance. And I'm being asked to remind you all, if you want CMEs, you need to register. The QR codes are on the windows. You won't be able to register after tomorrow, but you can register after we're done here. All right, thank you.
Yeah, I don't think the residents want pro boxes, right? So the prizes have to be more than. All right, can you hear me now? Okay, that's good. No, I was just commenting on the fact that it was a good evening. I really enjoyed the presentations. Don't watch my demeanor, that's fine. All right, so we were asked to make some assessments for some various prizes, which I'll share with you in about a minute or two, but I just wanted to just share with you a few general comments or critique of the presentations. Now, as residents, I know that you are primarily being clinically trained and the language of research sometimes may seem a bit esoteric and so on. But there are certain fundamental constructs that we would wish for you to understand as you move forward in your career. Science tends to be very precise in terms of what it is that we do. I see, for example, a lot of you, in terms of your aim statements, you use terms like influence. I don't know what that means. I see you use terms like you're going to analyze the prevalence. We don't know what that means. We see things that you're going to evaluate. Evaluate what? We don't know what that means. You need to be very concise and specific in your objective statement or hypothesis statement. Typically in a research, you're either looking to count something, you're looking to find a difference between something, or you're looking for an association between some matters. So those are the sort of keywords that we would expect to find in your aims or hypothesis, all right? I don't know what influence means. I'm not a social influencer. All right. Now, some of you made presentations where clearly what you are trying to do is to summarize a big body of data, probably from your book or something, and you're trying to put it into a 10 minutes presentation. But the key things when you're trying to summarize there is that clearly in your 10-minute presentations, you have to make some calls. So you may, for example, decide in your big book that you're doing on 3 specific objectives. But for this 10-minute presentation, you may just decide you want to choose one. Now, in choosing that one, you still can't use all of the literature review, all the things to review for one. You need to be relatively specific. So we found, for example, that when you said what your aims was, you gave me results, your discussions and your conclusions are not matching because some things were missing, some things weren't emphasized. So it's important when you come in, health communication or scientific communication is one aspect of research. Doing it is fine, but you also need to be able to communicate it. And in communications, there are different, depending on the environment. Sometimes we give you 10 minutes, sometimes we give you 15 minutes, sometimes we give you 3 minutes. The idea is that you need to be able to master communicating in a relatively short space of time. And so what I found was that there was a lot of disjointness between what you probably had in your book and what you're trying to take out of that book to present here in 10 minutes. It just needs some tightening up, all right? It needs to be one-to-one. What the hypothesis is, the method needs to match that, your results need to match that, and your discussion and recommendations need to follow through from that. All right, so those were a couple of the things. Now let's go to the prizes. As I said, most of you did well, don't feel bad, all right? The most innovative project we thought had to do with the zebrafish. Zebrafish. And we need to have more of those collaborative efforts between basic science and the clinical sciences, but we thought that was the most innovative project. There are some technical issues with that project though, which Maxine pointed out some of the technical issues. I also have some technical issues with it, but overall we thought it was the most innovative. The project most relevant to our local scene was a very close toss-up, but we decided that the ICU presentation would get that one. All right, the best presenter in terms of delivery of the material, even if the information was not outstanding, that's the qualifier, was a presentation by Gore. So that presentation was entitled, "Is Increased Boarding Time in Emergency Room of an Urban Hospital Associated with an Increase in Hospital Mortality and Length of Stay?" The only caveat with this one is that clearly the presenter wasn't too familiar with some of the analysis that was done. However, we thought they answered most of the questions were tossed their way efficiently and effectively. But it's important, one key thing though is that you really need to know how the model was built, all right? Because the examiner may ask you, what's the most parsimonious model for your data? Which essentially, what's the best model fit for all the bits of information that you have, all right? And then we come to the prize of all prizes. Taking into consideration all the various attributes that we were asked to score in terms of the delivery of the presentation, how the presenter responded to questions and challenges. The consensus of the judges was that the overall best presentation was a paper out of accidents and emergencies. Is it accidents and emergency? Yes. With a supervisor by Hudson. Section of Emergency Medicine, Department of Surgery, Radiology, Anesthetics and Anesthesia, Intensive Care and Emergency Medicine. Is increased boarding time in the emergency department of an urban hospital associated with an increase in hospital mortality and length of stay. Congratulations, Dr. Gore. I think we attributed you as the best presentation. All right. That's it. Yeah, we don't have
No, not yet. We have the prices, as I said, what's that? Yeah, no, as I said, there are physical prizes to be had, and we'll sort that out with Laurel. So that's Dr. Baker.
Yeah, Dr. Soares, a reminder to the residents and staff that there is a monthly research meeting hosted by the department where studies and research projects at all levels of completion can be presented and discussed. You can present it as many times as you'd like so that it can be refined, pre-ethics, post-ethics, when you've gotten your data, whether or not you need the department to do your analysis or not. Right now, it is utilized quite a bit by ophthalmology. Second in line would be orthopedics. There are some sections that do not send any papers for any type of help. A lot of the questions that were raised and where there were difficulties answering today could have been addressed in those meetings. So please avail yourselves of all the tools available.
Because that's exactly what that's subjective. Maybe he thought it was. Come Professor Gossel Williams, our Deputy Dean in charge of research.
Yes, so I just make some comments in that capacity. So as the presenters, you all did very well. And in spite of what Prof. Reed said, I can tell you that he's really proud. He was the Deputy Dean for Research before I took over, and he really has worked well with Suredic. I am really impressed to see how the department has come together. So we had anesthesia, emergency medicine, and radiology all together in one. And I was really pleased with the fact that you've now embraced the concept of not just 20 case reports, but that you are now doing some research. So the other aspect that Prof. Reed had started is the actual conversion to papers. That's what we want to see. The dean has actually advised all program directors to find a way to integrate a publication-ready paper in the write-up. So I would love to see that. So at least when you are all gone off in your sojourn, relaxing on the beach and on the cruise, at least your supervisor has something that they can translate and move forward. Thank you again, and I look forward to being at more of these kind of presentations.
Thanks, Professor Williams. Oops. So I'm going to move the vote of thanks. So I'm exhausted. Please forgive me. Here comes our fearless head of department to give his comments.
Colleagues, I promise you, I am going to be very brief because I know that only myself and Deanne stands between you and the food. So I'm very cognizant of that. But it would be remiss of me, you see, Deanne is going to move the vote of thanks and she cannot thank herself. So as head of department, I would like to say on your behalf, thanks to Dr. Soares, for coordinating this and putting it together, and also thanks to Ms. Laurel Bennett in the Department of Surgery for supporting her. You know, as I said, yes, I'm going to, so the judges are going to be formally thanked by Dr. Soares, but I'd like to say thanks, and I really value the comments that have been made by them. I just want to say something very briefly. It's only going to take 20 seconds. The only thing that separates us from a college or a polytechnic is research. That's what universities do. We create new knowledge. And believe me, I am exceptionally proud this afternoon to see the research coming from our residents. Our full-time academic staff, I must tell you, is dropping the ball on research. I've spoken to them about it. The university requirement, 2 research papers per year per academic staff. We are falling well below that, but there's a solution. If all the residents, instead of writing a book or instead of writing a full book, engage in research supervised by a member of the department that is publishable, then the research output of the department will increase. So I am encouraging all of you to think about that, think about doing research instead of writing a book of 20 cases. And if you do that, there's no doubt that the research output of the department will increase. Thank you, Dr. Sir.
Thanks, Professor Aiken. I find your closing point very interesting because when we got the mandate to write these research projects with a minimum of 8,000 words, I challenged it. I made no friends. So that's not up to us. So it's still a regulation that we try to follow. So I thank everybody who came to support. I threatened my residents while this was in progress because I said, please pay attention to the fact that we have some serious experience and expertise here, and the teaching is not to be missed. There is research that you are meant to be doing. Whether or not you are interested, you agreed to do it. So you might as well avail yourself of what we try to provide. Thank you to all the presenters for engaging. Most of you managed to come to the sessions that I had. I enjoyed working with you, even though I was exhausted by you. But I thank you for your enthusiasm and your presence. I would like to thank our sponsors before I forget. So the prizes have been provided by ENS Power Solutions, that's my solar providers, by Heather Lane, who dressed me today, as usual, when I'm presenting at the meetings. So we have had these meetings. First time I've had the pleasure of having Professor Gossel Williams here, but I've cheered 3 times in the past, and Heather Lane always faithfully dresses, and they've provided one of the prizes. And then another prize was, pardon me? I don't think so. No, they don't do suits. They do some things for men, but it's mainly dresses and keeping the ladies looking sharp, but comfortable also. And so they provided a prize as well. And then we got, we have our MPS spokesperson has presented, and she has provided some refreshments for us. And Francis Renee one of my friends and associates, she also provided one of the prizes. She's actually an artist. So there's a little bit of an artwork for one of you guys. And I will not forget my good caterer, don't worry. He has given us some sweet treats to go with the finger foods. So there's some chocolate fudge there for those with the sweet tooth. All right, so I am being told to wrap up now. Everybody's dying to go. Thank you all, and I cannot not thank MITS. Please, Damian and team, thank you all so much. Thank you for my timekeepers, Sister Ferron Booth, who has been a part of the support system for a long time, and she's post-retirement, and she has not given up on us. Thanks, Dr. Craigie, who came in at the last minute to fill in, to help assist with the timekeeping, and Laurel has been thanked. Thanks for all the consultants who made the time to come. Thanks to all the residents who came. I hope you all learned something. So I think I've thanked everybody. We have thanked them several times. So we thank you again. So, and you see, everybody is so glad to have you here, and we are in awe of you. We can't outperform you in certain cases, but when you come for your MR or whatever, we promise to do our best for you. All right, you take care. Thank you, everybody. Enjoy.